Welcome to the second day in the annual conference of Ketotic Hypoglycemia International. I'm so happy to welcome you all back after a action-packed day yesterday where we met the experts from the Scientific Advisory Board, and we were fortunate to hear family stories from Ketotic Hypoglycemia International. Today will be no less exciting. We will have presentations from experts from around the world. We will hear from rising stars, new researchers in the field of complex hypoglycemia. For those who were not present yesterday, I just want to highlight this QR code we have on the screen. Since last year, we have been able to organize ourselves, so we are now ready to fundraise. We have chosen to fundraise the first ever PhD in Ketotic Hypoglycemia International. This PhD has been done in collaboration with the Scientific Advisory Board, but most importantly, the families and the most urgent need of these families. So if you feel like you have the means and the funds, please support us and support this PhD to become a reality and support the research into idiopathic ketotic hypoglycemia. Also, we are going to hear both scientific experts speak today, but we are also going to have a lot of family stories. At the end of today, we will have a whole section approaching the very sensitive topic, Munchausen by proxy in ketotic hypoglycemia. So stay tuned and watch the whole program. I'm sure you will not be bored. The next presentation, or actually the first presentation of today, we are here to introduce to you all our latest member of the board of directors. I am so proud to present to you all Giovanna. Here you go.
I'm Jovana Vlajković-Josić. I'm born and raised in Belgrade, and I live in Belgrade. I'm a mom of 3 girls. That's definitely the most important thing about me. I'm a medical doctor working as medical director in Syneos Health. Syneos Health is a contract research organization. So basically, my work in the past 18 years is about clinical trials and new medicines that I'm very passionate about. I'm also an immunologist and specializing in clinical pharmacology. So again, something about new drugs and research is really my passion. Um, when I became mom in 2013, I gave birth, let's say, a little bit later than planned, but a little bit tinier girl that we were all expecting. And Olga was born when she was only 2.5 kilos. I took her home, and like any first mom, I didn't know what what to do with her. She was constantly nursing. She was attached to me almost all the time, but she was thriving well. Um, Otherwise, she was really happy and healthy and thriving well until she was about 20 months old. So nearly 2 years, when I noticed that she's after one night of fever, she was still feeling sleepy and still feeling very, very weak. I took her to the physician, and we agreed that we should take her blood to see what's going on. She was barely awake that morning. They took everything they could from her finger, and it included the blood sugar, the glucose. The lady from the lab called me an hour later and asked, "Does your daughter have diabetes? She has a very low blood sugar." And I was shocked. I thought that she has some viral infection. Um, that was not diabetes. That was idiopathic ketotic hypoglycemia. Um, and with the help of my very good friend, and she's our pediatrician, she told me, "Oh, don't worry about that," because I called her and I was like, what I'm supposed to do now. She has a very low blood sugar. Does she have a diabetes? Is she going to have a diabetes? Um, and then she told me, no, this is just ketotic hypoglycemia. Don't worry about this. So, as a physician, you are trained in some basic things. I couldn't find anything about this condition. But I learned that this is something that should be benign. And I took some steps to prevent that. So, each time Olga had infections or had any type of distress, she was getting a low blood sugar, and this was very stressful because usually when the kid is sick, she cannot eat, or you cannot just force her to eat. So we lived like that for a few years and trying to manage that. One time we even ended up in a hospital uh, because she was so dehydrated she couldn't even eat or drink anything. And after a few years, it became to be better. She got a little sister, Vera, and another little sister, Nada. And she is now happy 8-year-old. Um, all of this time, we like I said, we had a few episodes. We had a few things when we really had to think about this condition. And whenever I tried to search for that, it was just 3 sentences, and that was all. And I really couldn't see anything beyond that. In 2021, I started working in Sinas Health, and in my first month, we had a rare disease consortium meeting where I heard presentation from Danielle, and it was so powerful. First, even if I don't have this experience, this presentation was so powerful and so sincere that I was literally crying. And there was, like, she was presenting this to us, maybe few dozen of us on the other side, and we were all silent and just listening to that. So I wrote to her, Danielle, this is something um, that was so powerful, so touching. It could be me, because I had this experience with my daughter. And Danielle said, "Oh, really? This is something that we are researching so much." She told me about the paper that was issued by the KHI. This is how actually I learned about KHI, learned about Danielle's story, and Danielle invited me to join the KHI. I'm hoping to help as much as I can with first with my personal experience that I have, and also with the passion and my work in research organization. This is really something that I'm very excited about, and I think the more I'm here, the more I'm learning. I'm hoping to be someone who will really support them in all of their great activities that they are doing. So I'm very proud to be part of the KHI family. I would like to thank you all, and I wish you a great conference. Thank you and goodbye.
Welcome back to the second day in the annual conference of Ketotic Hypoglycemia International. You have all just met our latest board member, Giovanna, and now we're moving forward to a section on the program called Living with Ketotic Hypoglycemia. This first presentation in this section is done by an amazing researcher at the Children's Hospital of Philadelphia. Presenting to you all children presenting with hypoglycemia in the settings of intercurrent illness, a retrospective study. Here I give you Dr. Elizabeth Rosenfield.
Hello, I'm Elizabeth Rosenfeld, instructor in the Division of Endocrinology and Diabetes at the Children's Hospital of Philadelphia, presenting a retrospective study evaluating children presenting with hypoglycemia in the setting of an acute illness on the behalf of our group. I have nothing to disclose. The prevalence of undiagnosed hypoglycemia disorders in children evaluated in the emergency department for any reason who were found to have low plasma glucose at presentation has been estimated to range between 10 and 28%. During illness, children often have reduced oral intake, and in this setting, hypoglycemia can occur either due to prolonged starvation in children with normal fasting tolerance, that is to say, children without an underlying hypoglycemia disorder, or alternatively can be the initial manifestation of an underlying hypoglycemia disorder that requires prompt identification and treatment to prevent further harm. Differentiating between these two groups of children and consequently determining which children with hypoglycemia detected during acute illness require endocrine evaluation presents an unanswered clinical challenge. We aim to address this gap by evaluating the yield of conducting a diagnostic evaluation in children with hypoglycemia detected at the time of presentation for an acute illness, and by describing the clinical and biochemical features associated with identifying an underlying hypoglycemia disorder. This was a single-center retrospective review of all children referred to endocrinology for the evaluation of hypoglycemia in the setting of acute illness between January 2013 and December 2018. Inclusion criteria included age less than 18 years of age, documented plasma glucose less than 70 milligrams per deciliter or 3.9 millimole per liter, and illness symptoms, including fever, vomiting, diarrhea, or upper respiratory illness symptoms at presentation. Children with previously recognized hypoglycemia disorders, diabetes mellitus, or use of medications that can alter glucose metabolism, including insulin, oral hypoglycemic agents, systemic steroids, chemotherapy, or beta blockers, within 1 month of presentation were excluded. A note is made of the relatively high plasma glucose threshold used for defining hypoglycemia in the study. Here, we aimed at casting a wide net by setting the threshold to identify our cohort at less than 70 milligrams per deciliter, or 3.9 millimole per liter, understanding that the yield of identifying children with an underlying hypoglycemia disorder would be higher the lower the threshold utilized. Out of 1,410 children referred for evaluation of hypoglycemia, 145 children ultimately met inclusion criteria and were included in the analysis. Medical charts of these 145 children were reviewed. Age at presentation in years of our study cohort had a median of 2 years and an interquartile range of 1.2 to 3.7 years. But notably, the overall range for children in this study was from 2 days of life to 11 years of age. The cohort was slightly predominantly female at 55% and was predominantly white, 62%, with 22% reporting Black race, 4% reporting Asian race, less than 1% reporting American Indian or Alaska Native, and 9% reporting themselves as other. Additionally, there was very low prevalence of Hispanic ethnicity at 2%, and the majority of children included in this cohort were both of normal weight and normal height. 20% had a prior history of hypoglycemia that had not been evaluated prior to this acute presentation. With regard to the illness features at presentation, gastrointestinal illnesses were most common, with the majority of the cohort reporting vomiting, diarrhea, or both indicated as gastroenteritis here. In roughly 2/3 of the cohort, the duration of illness at the time of presentation was relatively short, between 1 to 3 days. We intended to evaluate the role of duration of reduced oral intake, or as a proxy for the duration of fasting in these children, given that hypoglycemia and illness may occur in children with normal fasting tolerance but prolonged starvation. But as noted in the graph on the right, this information was not available by chart review for almost half of the cohort. So in addressing our first aim, what is the yield of conducting a diagnostic evaluation 4 hypoglycemia disorders in children who are incidentally found to have hypoglycemia at the time of presentation for acute illness. We found that out of 145 children included in the study, 69, or roughly 48%, underwent a diagnostic FAST evaluation. And of these children, 12 were found to have an underlying hypoglycemia disorder. No diagnoses were established in children who did not undergo a diagnostic FAST. And so overall, a hypoglycemia disorder was identified in 8% of the cohort of children who were found to have plasma glucose less than 70 at the time of an acute illness, and in 17% of those children who underwent a diagnostic FAST. This slide documents the diagnoses that were identified in our cohort. And diagnoses included 7 children with hyperinsulinism and 1 child each with impaired hepatic insulin clearance due to acute hepatic insufficiency, fatty acid oxidation disorder, growth hormone deficiency, 3-methylcrotonol-CoA carboxylase deficiency, and dihydrolipamide dehydrogenase deficiency. Here, the diagnoses have been categorized by the levels of metabolic fuels obtained at the time of hypoglycemia or the time of critical sample during the diagnostic fast, as described in yesterday's presentations on fasting adaptation and fasting studies. As you can see on this top line in blue, the majority of diagnoses established were those with biochemical findings of no acidosis and low ketones at the time of hypoglycemia. We next aim to describe chemical, clinical, and biochemical features associated with identifying an underlying hypoglycemia disorder. To do so, we compared baseline and demographic factors between the 12 children in whom a diagnosis was established and the remainder of the cohort of 133 children in whom no diagnosis was made. We found that in children in whom a diagnosis was established, these children had a lower median age at presentation of 1 versus 2.1 years of age, and had a higher mean bicarbonate level at presentation of 22 versus 16 millimoles per liter. In contrast, no statistically significant differences were observed between groups with regard to plasma glucose at presentation, measured either as median value, which was 45 milligrams per deciliter, or approximately 2.5 millimole per liter in both groups, or assessed categorically, depicted here, as the percentage of children in each group presenting plasma glucose less than 50 milligrams per deciliter, or approximately 2.8 millimoles per liter. Children with an identified diagnosis were less likely, statistically significantly less likely, to have ketones greater than 1 millimole per liter at presentation, which was 25 versus 92%. No statistically significant differences were observed between groups with regard to the other parameters assessed, including sex, race, weight or height status, a prior history of hypoglycemia, symptomatic hypoglycemia at the time of presentation, or the presence of abnormalities on labs other than plasma glucose, beta-hydroxybutyrate or ketones, or bicarbonate at presentation or on outpatient endocrine evaluation. In summary, we found that younger age, higher bicarbonate level, and lower ketones at presentation were statistically significantly associated with identifying an underlying hypoglycemia disorder. However, these findings should be taken into the context of the inclusion of neonates and infants in this cohort, and consequently the likely associated high rate of hyperinsulinism that was detected. Next, because a diagnosis was only established in those children who underwent a diagnostic fast, we explored whether there were any factors associated with performing this evaluation. We found that plasma glucose was lower in those children who ultimately underwent a diagnostic fast, as depicted in light green here, as compared to those who didn't, depicted in darker green. Plasma glucose in this group of children who underwent diagnostic fast was 40 milligrams per deciliter, or approximately 2.2 millimole per liter, as compared to 47 milligrams per deciliter, or approximately 2.6 millimoles per liter in those who did not. But there were no statistically significant differences in the other factors assessed, including age and bicarbonate level at presentation as depicted here. nor in the other clinical or biochemical features at presentation as depicted here, with the exception of plasma glucose emerging again as statistically significant when looked at categorically, looking at the percentage of children with plasma glucose less than 50 at presentation versus greater than 50 at presentation, milligrams per deciliter that is, which was 80% in those who had a diagnostic fast versus 62% in those who did not. So ultimately, it seems that a lower presenting plasma glucose did seem to be associated with likelihood of having a diagnostic fast established, whether that was looked at as a continuous or categorical variable. Now, I'm sure at this point many of you are asking, what about those children without an identified diagnosis? And so of the 145 children that were included in this cohort, 133 did not have a diagnosis identified. This represents 92% of the overall cohort. And of these children without a diagnosis identified, 42% underwent diagnostic fast that was unrevealing, and 21% had genetic testing performed that was again unrevealing. What's more, 30% of these children in whom no diagnosis was established had recurrent episodes of hypoglycemia over the study follow-up period, which had a median of 2.25 years. And these findings really, in part, highlight some of the challenges that are inherent to identifying underlying ketotic hypoglycemia disorders. This is because ketone formation is a normal response to fasting, but also occurs in underlying pathologic conditions. And children with recurrent ketotic hypoglycemia due to pathologic causes will have elevated ketones and normal hormonal concentrations at the time of hypoglycemia. A critical sample laboratory does not necessarily distinguish these children from those children with normal fasting. Looking at the fasting profile during a diagnostic evaluation, that is the relative progression of glucose and ketones over the fasting period, can give clues to this and to distinguish between children with normal fasting tolerance and those with underlying hypoglycemia disorders with ketone formation. But these features were not specifically extracted as part of this work. To discuss some limitations and considerations of the study presented, it's notable to mention that this was a retrospective design, and so it was subject to inconsistencies or omissions in the documentation that might be present in an electronic health record. Additionally, this was a selected cohort of children in whom a plasma glucose was obtained in the emergency room, an endocrine referral was prompted, and subsequent evaluation was conducted. These steps in the process were all at the discretion of the ordering provider. And while we attempted to look at some biases in the latter of these, that is, what factors might influence which children have a diagnostic fast conducted, the others and potentially unmeasurable factors by nature of this retrospective review could not be addressed by the study design. And lastly, a note needs to be made with regard to the generalizability of this study. This was a single center study that was conducted at a large children's hospital with a specialized hypoglycemic clinic. And thus, our findings may not be generalizable to different populations. In particular, populations including children with different age distributions, given the inclusion of neonates and infants in this cohort and the influence that this may have had on our findings. In conclusion, 8% of children with hypoglycemia during acute illness were found to have a previously undiagnosed hypoglycemia disorder in this study. And this number increased twofold to 17% when we looked just at those individuals who had a diagnostic fast evaluation. We found that younger age, higher bicarbonate level, and lower ketones at presentation were associated with establishing a hypoglycemia diagnosis. However, in contrast, or as the other hand of these findings, 92% of children were not found to have an underlying hypoglycemia disorder. And these findings highlight that guided endocrine evaluation is needed for all children presenting with hypoglycemia, regardless of whether or not there's precipitating illness. This is because if we do not look for these disorders, we will not find them, and we won't be able to target or tailor treatment to prevent future or unnecessary harm. We thus recommend that endocrinology should be consulted to help guide the diagnostic evaluation in these cases. I'd like to thank our patients and our families, the co-contributors to this work, Drs. Diva De Leon Crutchlow, Ahud Al-Zarani, and our research team that contributed to this work, Lauren Mateer and Heather Bong. Thank you so much for listening, and now I'd be very happy to take any questions you may have.
Welcome back to the second day in the annual conference of Ketotic Hypoglycemia International. Every time I hear these presentations from new, young, emerging researchers interested in the field of ketotic hypoglycemia, it simply fills me with hope. Because even though we have the best experts in the world, we still need more young researchers be interested in this field of complex hypoglycemia. So now we are moving forward to the first patient story of today. I am going to present to you all a story about a little boy called Anders.
Hi, my name's Anders and I'm 6 years old and I live in Melbourne, Australia. I have idiopathic ketotic hypoglycemia. My mom's going to tell you my story.
I'm Anders' mum, Leah. Anders is my second child. He arrived by elective C-section in January 2016. He stopped breathing at 40 minutes old. As we watched them work on him, a code blue was called and he was rushed to NICU. My mother's instinct has been screaming at me since this moment that something is not right with Anders. This is our story and our fight to get answers for Anders. After the code blue, he was admitted to NICU. He kept vomiting up his feeds. After a couple of days on a drip, he started drinking. All tests were fine, and we were discharged home on reflux medication. Nate, which is Anders' older brother, had severe laryngomalacia, which is a floppy larynx. He required surgery for this. Anders also had this, but his was mild, and for a while we thought all his issues were related to this. Feeding Anders became very difficult. Sometimes he would be really starving, and then other days he wouldn't want to drink at all. And he would vomit at random times, not just after a feed, like normal reflux. He was so inconsistent. Anders started to lose weight. Our GP sent us to emergency. After 2 days in hospital, we came home and continued struggling along. He made no sense. This inconsistent feeding continued. He would lose weight and become dehydrated from not drinking or from vomiting. When he was in hospital, he required a drip to be put in or an NG tube. Then he would perk up and we would go home. This happened over and over again. These admissions were exhausting mentally and physically. When they did tests, the days in hospital turned into weeks and months. Our longest admission was 3 months long. He was always worse at home. We guessed because he had the NG tube in hospital. I was still attempting to work and study, and the family was split. It was quite hard. I decided to change hospitals to get some fresh eyes. His new team really wanted to help and they thought of everything they could, but test after test came back negative, and this just continued. Anders used to scream and cry for bananas to eat all the time, like he would beg us for one, and then he'd shove it in so quickly that he didn't even have time to chew it. When he was around 2, he was unwell again, and he wanted a banana. We gave him one, and he ate it so fast that he was gagging and choking. We had to give it to him in little bits so that he wouldn't vomit. He then vomited it all back up again, and then he began to madly start picking up the vomited bits of banana and started shoving them back in his mouth again. We took it off him, and he was just beside himself. I've never seen anything like it before in my life. At this point, I was grabbing the bags to head to hospital, when my sister-in-law, who was also a diabetic, said I'll check his sugars. He had high ketones. I had no idea what this even meant, but this was the first time in 2.5 years that his sugars or ketones had actually been checked. We turned up to ED and I told them that we had checked them. The nurse then checked his again. I don't know what levels they were because at the time I had no understanding of the numbers, but I remember the nurse's face, and then she quickly ran out of the room and we were taken into resus. When I was asked by the doctors what's wrong with him, I just kind of said, we don't know. He just kind of crashes or does this when he gets sick. My heart breaks, like at the thought of my poor little boy having such low blood sugars for 2.5 years, that his body was telling him to actually eat his own vomit. He couldn't talk and he couldn't tell me. I feel so horrible about it, but then when I think about it, even when we knew about the low blood sugars, they still dismissed us time and time again. It was at this admission we saw endocrinology, and a referral was sent off to metabolics. This referral was lost once, then the next time someone had called up and told them that Anders didn't need to be seen. The third time, a message from metabolics was not passed on through the team to me, and so he wasn't booked in. Anders didn't see the metabolic team until he was 5 years old. This is nearly 3 years after he was being told that he needs to see the metabolic team. He presents as a metabolic kid. We did a planned hypo study and he failed miserably, or you could say he passed, I guess. 4 new IV lines, way too many blood sugars to count. He barely dropped below 2.5. We have no idea why, and it was the most frustrating admission of our life. The following day, an hour after having lunch, he dropped down to 2. Unfortunately, they had their test results, and from this point on, I was told over and over again that he doesn't need a nighttime feed and that he's safe to go over 12 hours without eating. There is no need for any admission before any surgeries, and it just continued. This test was meant to be a positive one, and it was meant to give us some answers, but now it was just working against us. Comments from medical staff that we got when we talked about ketotic hypoglycemia included, "What, he's had it once in his life and now you say that he has it?" This is not uncommon. We see multiple children a week with this. "He just needs some fat on him." "Oh, so he needs some insulin?" "Ketones don't matter. Don't even check them." "Just don't check any of them and he'll be fine." "Only treat him if he falls below 2.8. Anders went home with his NG tube and he had it for a couple of years. Then we went to a PEG. It was really good, except it didn't come without its issues. There were lots of infections at the start, and then the team then used it against us in the end. We had to keep presenting to ED the same as we ever did before. Instead of a baby, I was now carrying a skinny, nearly unconscious toddler into the emergency room and then taken into resus. Pediatric resus. I wish the place never was needed. Children have to be so critically unwell or injured to come into these bays. It's a place that you see in nightmares. A place where labels on the cupboards read heartbreaking things like pediatric bereavement kits, intubation kits, and life support equipment. It's such a cold place. It's not like any other emergency room with the bright coloured walls. Parents' lives are changed forever in this room. When you're in there, you start to think, why are we even in here? How did our life become a part of this? Ketotic hypoglycemia does. The part about ketotic hypoglycemia that is most frustrating is that no one believes you. Anders was so critically unwell that paramedics had to call the MICA for backup, and he required resus admission. Then on the ward, when his team came up to visit, he was a firecracker. He was eating breakfast, he was cracking jokes, he was running up and down the hall having races. And then they say, he doesn't need to be here, he can go home. Not once had his team ever seen that critically ill Anders in resus. They think he doesn't exist. Because how possibly could a child that would be so critically ill and be in resus be able to run around the halls of the hospital? A kid with ketotic hypoglycemia can. It was so hard to work with medical professionals who don't understand ketotic hypoglycemia. And I have so much respect for the ones that use parents as resources to learn. To protect my baby, I found out everything there was to know. I read every study, every article, every story there was to know. I asked questions that doctors couldn't answer, and some of them didn't like it. But that's not my problem. I have watched my child suffer, and I suffered. I wasn't rude, but I made it clear that I was over my son not getting the care he deserved. We changed teams again. Some of my teams are the ones from the very beginning, and I'm so grateful for their support, and they understand what we've been through. It got to the point that because all the tests had come back negative, that they were talking about removing the peg and not doing blood sugar testing. We were not being believed, yet the hypos were getting worse and worse. I was scared when I put him to bed at night, and I was worried he wouldn't wake up in the morning, or that we'd be in an ambulance by 7 a.m. I knew they were going to call child protection because of the questions they were asking. They still hadn't seen him in resus, and I knew we still didn't have a reason for why these were happening. They refused to refer us to genetics, and I still hadn't heard from metabolics. I was holding on to hope that this metabolics appointment would be soon. Every appointment I went to, I would ask them for an emergency plan and would ask them when the metabolic appointment would be. It was so hard to get any help in an emergency without the plan. The closest plan I could find was a plan used for Russell-Silver syndrome. It was essentially the same as ketotic hypoglycemia, and this condition actually fit Anders, except for he was too tall, and we looked into it. I used this as a guide, but made it very clear that he didn't have it, but for the first time, the emergency staff understood and could follow. I was desperate, and we kept getting refused this simple thing as a plan, and it saved me having to explain it all while he was so sick, but the doctors still didn't realise this. Even something as simple as do not give him insulin. His next hypo happened 3 weeks later, just before his 5th birthday. We were up in hospital and they said they were going to keep us for a couple of days. Metabolics arrived. I was so shocked, but I was also really excited to talk to professionals who actually understood him. And finally, I'd hope for his future. Half an hour after they left, Child Protection came into the hospital room. It's like I'm struggling at sea, and I've come up for air and I've screamed for help. Instead of throwing me a life ring, they pushed me back under the water with their foot. I started doubting myself. Maybe I am crazy. Maybe this is all in my head. I gave up. I wanted to fall under the water and stop fighting. What's the point? They're never going to realise. Maybe Anders needs to be put in somebody else's care. These events would still keep happening, and then maybe they'll finally realise. There was a team meeting, and I got my emergency plan. I had been waiting for this. Years I'd been asking for this. Why did they only do it when Child Protection were called? Who is going to help my son if they think I'm doing this to him? No one. He's still going to be suffering, and there is nothing I can do about it. They have attacked and questioned the only defence I ever had. That was that I am a good mum and that I'm fighting for my son. I had nothing left. They had broken me, and if they believed that I was capable of all these things, how long until everybody else in my life did too? I felt alone, more alone than I'd ever felt before. We were still in hospital. Nurses would stop talking when they came past. I was being talked about and judged by people who I'd got to know personally. It was awful. The pain I felt in my heart and my stomach was unbearable. Had I fought this long just to end up defeated? How could they blame me? They were the ones that were playing with his life. They stopped his peg feeds, and I was not allowed to use it. But I could take him home. This was only because most of the things they had accused me of, I could prove were inaccurate by emails that I'd sent. And professionals that trusted me spoke up for me, and I'll be forever grateful for them. At home, I turned my phone off and laid on my bed and cried for hours and hours, wishing it was a bad dream. The next morning I woke up and decided this could be a good thing. We might get some support. I was going to fight this. I wasn't guilty, and I was going to tell everybody about it. I'm not guilty. People need to realise that this is what the system does to undiagnosed children and their families. I said, do whatever you want. You will see that it's not me. I'm trying to help him. Someone actually came to our house to supervise meals. After being there a minute, she told me I was an amazing mum and that she didn't know why she was here. She knew I was doing the best I could. She sent the report to Child Protection. In the 7 months that Child Protection were involved, Anders ended up in resus 7 times and had to be admitted to hospital each time. 3 of these hypos, he wasn't even in my care at the time, making it impossible for me to have done anything to cause them. Child Protection closed and deemed Anders' issues medical. Surprise, surprise. I think the worst part about them contacting Child Protection was that by doing this, they dismissed everything we had been through over the last 6 years. The pain, trauma, stress, even the financial cost. Anders' father and I separated, not just because of Anders' condition, but it was a really stressful time. Anders and I were in and out of hospital and they were at home with Nate. We didn't get that quality family time. We both had different coping mechanisms and it's hard to help each other when you're both struggling yourself. Anders' brother was 3 when Anders was born. This was the time in his life he really needed help with his development. I forever regret that I wasn't there in his life when he really needed it the most. At the drop of the hat, he was sent to friends' houses or grandparents' houses, and it was really hard on him, though he has turned out really great. But it's hard to see his little brother go into an ambulance. During the Child Protection investigation, I came across Ketotic Hypoglycemia International, and my life changed. I sat there reading these comments from the other parents, and I cried happy tears. No one truly understood what it was like, and suddenly there were others like us. They had been through all the same things. Some of the stories were identical. I wasn't alone. I had people who could give me advice, people who knew more than I did. This gave me the strength I needed. I always had so much support around me, and so did Anders. But this support was different. This support was from people who were living this day to day. Later on, at one of our admissions, I had this lovely doctor who came to see us as she started her shift. The following morning, she decided to pop up to see us on the ward before she knocked off. She walked into the room and she was shocked. She said, "Where is his critically ill twin?" She said, "I wouldn't have believed in this if I hadn't seen it with my own eyes." My heart sank, and I said, "This is exactly why Child Protection has been called. This is exactly why they want to stop testing his blood. ED and the team do not see the same child." Later that day, I got a call from the metabolic department, and I was told that they wanted to see Anders, but somehow the appointment wasn't made. I don't know what happened, but it was pretty convenient timing that the appointment time wasn't handed over, especially due to Child Protection being contacted. I've seen all of this slowly break my child, and it hurts so much that as his mum, I cannot protect him from the pain. As he gets older, he understands so much more and is able to verbalise what he's feeling, and I think that makes it harder too. He has anxiety, and when he feels sick, he's scared to tell me because it means he might have to go to hospital. This little boy has begged me not to hold him down and to let him go. I'm meant to be the one there to protect him, yet he looks at me and I can see the confusion in his eyes as they hurt him. To him, they are hurting him, and I'm allowing it. He doesn't understand that he could die or understand that these tests will help him. But the painful part is he's wondering why I'm not saving him. Why am I holding him down and allowing this? After this, he becomes angry. He's hurting, he screams and he kicks. I've broken his trust. I've hurt him. The nurses tell him not to kick. I tell them to let him. He can do whatever he wants. He needs to get this out of the system. The least I can do is allow him to be angry at me. He finally lets me hold him. He knows I'm there for him and he knows I love him. If I could take away all this pain for him and hold it forever, I would. I have anxiety and PTSD from all these experiences. I am forever hurt by the way I was treated by the doctors who were meant to help, and it will always stay with me. They failed my son. He was admitted to resus 7 times. I watched him in there 7 times, 7 hypos, 7 times he didn't have to be in there. He could have died. They took away his support. That isn't helping. Anders' KH journey is still not over. Thankfully, we've been seen by metabolics and they're as amazing as we thought they'd be. Anders has started on cornstarch and a midnight feed. We got the genetic testing done and we are now diagnosed with idiopathic ketotic hypoglycemia. I was devastated when the genetic testing came back negative, but I was so grateful to have it done. We have a new team and they are amazing. He's finally being managed well. And we are getting a new emergency management plan, one that we should have had from the start. I'm happy to report that Anders has gone a whole year without having a hypo. This may be because of COVID isolation and there hasn't been any bugs going around and he hasn't actually got sick, but compared to what he was having, he's doing amazing. I decided to tell Anders' story, not to tarnish any doctor, but to show everyone how little is known about KH and to raise awareness. I do not want any parent to have to go through what I had to. No parent should ever be made to feel like I was made to feel when trying to seek help for your child. But mainly, I do this, so what my baby boy had gone through will never happen to another child. I hope that no other child ever has to go 2.5 years having low blood sugars without getting treatment. He didn't deserve this. So many procedures, so many tears, and so much pain. I want his future to be happy and healthy and free from hospitals. I hold on to hope that an answer will come soon. He is so strong and he keeps me fighting. Because he keeps fighting. Since KHI, there's been a shift and I'm so grateful. And I look forward to the day when ketotic hypoglycemia will be a known condition. I'm so excited for the future and I have hope. Thank you, Ketotic Hypoglycemia International, and thank you to everybody who took the time to listen to Anna's story. Thank you.
So, welcome back. I guess I should have warned you that today is a day where some might need to bring some tissues because it's going to keep continuing with these patient stories. And many of them are heartbreaking, just like Anders. So, and yeah, I have company today. This is my daughter, Savannah, one of the whys of why KHI was established. Savannah has idiopathic ketotic hypoglycemia and she's with me today. Can you say hi, Savannah?
Hello.
Hello. Savannah says hi. And she saw her doctor, Henrik, so she wants to say hi to Henrik. And now we're moving forward with another presentation of a young emerging researcher within the field of complex hypoglycemia. So Henrik, han vinker. Henrik is waving. Thank you, Henrik. We are moving forward with the presentation Eating Difficulties, Proms and Prems by Dr. Anike Veneme.
Thank you for inviting me to give this presentation. My name is Anike Venema and I'm an MD-PhD candidate at the University Medical Center of Groningen. My MD-PhD project is about value-based healthcare for patients with glycogen storage disease, which is a rare metabolic disorder which results in fasting intolerance and hypoglycemia. My promoter is Dr. Derks, and today I would like to tell you something about eating difficulties in persons with IKH towards the use of PROMs and PREMs. I'm recording this presentation on the 10th of May. So today I would like to tell you something about the study that we performed on eating difficulties in patients with idiopathic ketotic hypoglycemia and GSD patients. And I would like to tell you something about value-based healthcare, PROMs and PREMs, and I would later discuss those terms. So first onto the study on eating difficulties. Why did we start this study? So in the clinic, it was observed that patients with GSD, also with IKH, were experiencing eating problems, and sometimes these eating problems were quite severe, so they were referred to SciCentra because the problems needed extra treatment. SciCentra is a center specialized in the treatment of eating problems in children, and this is located in the Netherlands. And there have also been some other studies on eating difficulties, especially in GSD patients, where it was shown that GSD patients show more dysfunctional attitudes towards food and have a lower body esteem than healthy persons. And in addition, GSD patients can have a selective food intake and can have fear to eat. There are no studies yet on eating problems in IKH patients, but because GSD and IKA patients can be quite comparable because they can both experience hypoglycemia and have to follow a diet, we also were interested in this patient group. And in addition, there were also organized mirror meetings where patients could discuss their healthcare. And in this meeting, it was also noticed that psychosocial problems needed more attention. So this gave an extra motivation to dive into this subject and do this study. So for this study, we included patients that were referred to CEST. So the center specialized in eating problems. And we did not only include the patients that followed the treatment there, but we also included patients that were that eventually did not follow any treatment. And it was a retrospective study, so this means that we only used data that was already available. So we used data from the medical files, and we did not only include the medical files from the University Medical Center of Groningen, but also from CEST. And in the medical files, we looked for a lot of data and mostly about eating problems. So for instance, we were looking for aversive symptoms, problems with some parts of the diet, or delay in eating, or when the eating problem started. So this was all gained from the medical files. So then on to the results. We included 4 patients with IKH, and they were all from one family, and we also included 12 GSD patients. And those GSD patients, and the IKH patients, they experienced a variety of eating problems. So for instance, they had problems with selective eating. So for example, they had problems with eating breakfast or vegetables or cereal products. And there was also observed that some patients showed some behavior of food refusal, like conflicts during the eating times or eating little food. And some patients also experienced a period of complete food refusal. There were also patients that experienced aversive symptoms during eating, so for instance, vomiting or nauseousness, and some patients also experienced hypersensitivity of the mouth, or they had no interest or a lack of interest in eating. And 2 of the 4 IKH patients were diagnosed with avoidance restrictive food intake disorder, which is an eating disorder. And this disorder is characterized by eating too little or selectively, and this is associated with weight loss, poor growth, and nutritional deficiencies. And therefore, there is sometimes a need for supplementary feeding. And this can also impair psychosocial functioning. And there are 3 types of this eating disorder. The first one is a lack of interest in food. The second one is an avoidance of food due to its sensory characteristic, for instance, the structure of the food. And the third one is a concern about the aversive consequences of eating the food. So a child can be afraid of vomiting because of eating. And in another study, it has been shown that this eating disorder has quite an impact on quality of life. So that's why it's really important to know more about this disorder and to diagnose it. So in this figure, you can see an overview of one of the IKH patients. And as you can see, this is a female, and she was 5 years old at the time of the research, and she was diagnosed with ARFID. And in the right part of the PowerPoint, you can see that she had a diversity of eating problems. So she had problems with breakfast, lunch, dinner, her late evening meal, dairy products, and also with cereal products. And there was also a problem with a certain part of the diet, with the uncooked cornstarch that she had to take before she went to bed. And she also had some hypersensitivity of the mouth. Sometimes she was gagging during the mealtime, and she had no interest in the food. And there was also a period of complete food refusal. So as you can see, in one patient, there is a variety of eating problems. And then an example of another patient. This was a boy who was 3 years old at the time of the research, and he was also diagnosed with avoidant restrictive food intake disorder. And he also showed a variety of eating problems. So he had a problem with a late evening meal, but also with vegetables and fruit. He had no interest in food, and there was also some behavior of food refusal. So sometimes during the meal times, he was turning his head away. He didn't want to open his mouth. He was eating little food, and there was also a period of complete food refusal. So this is what we found in our study. We also compared our results with other studies, and most importantly with studies that were performed in patients with other inborn errors of metabolism, as we can also learn from other disorders. And it has been observed that some children with inborn errors of metabolism, they experience poor appetite, a limited food variety, and sometimes lengthy meals. And there is also a retrospective study on the use of tube feeding in patients with inborn errors of metabolism, and it was shown that there was a decrease in oral feeding and total feed and other feeding difficulties after getting a tube into the stomach. And have also been other studies that showed that there is an association between food refusal and nasogastric tube exposure for more than 3 months in children with like other disorders. And after this study, we started to think about the next steps, and we would like to know which psychosocial and eating problems exist in the whole GSD and IKH population, as we believe that this is only the tip of the iceberg. And even more importantly, how can we prevent or diagnose these problems earlier? And for this, we can use the prompts, which I mentioned before. But first, I would like to briefly explain what value-based healthcare is, and because in value-based healthcare you can use prompts. So onto value-based healthcare. Value-based healthcare intends to achieve better outcomes for the patients and improve the quality of patient care and thereby reduce the costs. And by organizing healthcare according to the needs and preferences of the individual patient. In value-based healthcare, there are 4 pillars, so it's not only beneficial for the individual patient, but eventually also for society. And an important step in value-based healthcare are the person-centered outcomes. This is a standard set of outcomes that can be used, and this can improve the care for the individual patient, and it lets patients report on their disease, so it's more about the perspective of the patient and not the perspective of the healthcare professionals. And these sets have already been developed for some diseases, for example, diabetes mellitus, but it is more easy to develop those sets of person-centered outcomes for more prevalent diseases, for example, diabetes, because this is more high volume care and less complex. And for rare diseases, most of the time, this is low volume and high complex care. So that makes it a little bit more complex and complicated, but it can really help to improve the care, and those standard sets of person-centered outcomes can not only be used in healthcare, but also for research, and you can use them to see if there's a value, increase of value with your treatment or a new medication, for example. And as a part of my MD-PhD project, we would like to develop a standard set of person-centered outcomes for GSD patients, which may also be suitable for IKH patients. And to form this set, we will not only use the input from healthcare professionals and researchers, but also, and most importantly, from patients and their families. So we can create more value for the patients. And an important part of the person-centered outcomes are the prompts and the prompts. So the prompts. PROMPT stands for patient-reported outcome measures, and it is a tool to gain insight of the perspective of the patient about their life and different aspects of the disease. And most of the times, the prompts are instruments, for example, questionnaires, which can measure certain aspects of their life. And to give an example, to screen for the avoidant restrictive food intake disorder, you can use a questionnaire which is called 9-item avoidant restrictive food intake screening questionnaire. So this screens for this eating disorder, so you can see if you will, if a child or another patient may have this disorder. And in our study, we also identified 26 instruments that are already used in the GSD population to measure psychosocial problems or eating problems. Another thing that can be used in the person-centered outcomes are the PREMs, which stands for patient-reported experience measures. And this can gather information of the perspective of the patient, but this is not about their life, but about the care they receive. So it's more about the quality of care instead of their own quality of life. So to summarize, eating problems and even eating disorders can occur in IKH patients, and hopefully with value-based healthcare and the use of prompts, we can identify those problems earlier or prevent them. I would like to thank the people we worked together on for this study, both from the University Medical Center of Groningen, but also from Science Centra. So thank you for your attention.
Welcome back to the second day in the second annual conference in Ketotic Hypoglycemia International. We have just heard the presentation about eating difficulties in IKH, a topic that is really an issue within the families from KHI. And now we're moving forward with another young researcher. This is Dr. Alexander Rossi talking about the role of CGM.
Good afternoon, everybody. I would like to thank the organizers for inviting me today to present on the role of continuous glucose monitoring. And today I will summarize current evidence on diabetes and glycogen storage disease type 1. Continuous glucose monitoring is a medical system that continuously monitors glucose levels throughout the day. The frequency of recording varies according to the device, but it's usually one record every 5 minutes. In a CGM system, three major components can be defined: a sensor, a transmitter, and a receiver. A wearable sensor is attached to the skin and measures glucose through a subcutaneous needle inserted in the interstitial fluid. The sensor is coated with glucose oxidase and reacts with glucose, thus generating an electrical current proportional to the glucose levels. And this current is transferred to the transmitter, and eventually the sensor glucose measurement is transferred to the receiver. The receiver can be either a receiving unit or a compatible smartphone. When talking about continuous glucose monitoring, we should keep in mind that the device is measuring glucose in the interstitial fluid rather than in capillary blood. Compared with a conventional capillary glucose measurement, continuous glucose monitoring provides a much greater insight into glucose levels throughout the day. Particularly, it can provide information on the direction, magnitude, duration, and frequency of fluctuations in glucose levels. And therefore, it can help identifying and possibly preventing unwanted periods of hypo and hyperglycemia. In the figure on the left of your screen, you can see how the measurements appear, the continuous glucose monitoring measurements appear to a user. While on the right, you can see the results of the overall data analysis that are generated by the software connected to the CGM device. When talking about CGM, there are several considerations and several features that should be taken into account. The first point is calibration. Calibration is the process through which the CGM system associates a specific capillary glucose concentration with a specific electric current. This process requires the user to insert capillary glucose values into the CGM system. Thus, it is advisable that calibration is performed when stable glucose values occur, for example, before a meal. The amount of calibrations required per day vary according to the specific CGM device. And importantly, most recent devices are factory calibrated, thus do not require any input from the user. Second point to consider is the lag time. That is the delay between any change in glucose values occurring in the blood and the change that can be detectable in the interstitial fluid. Additionally, we should consider how we plan to use our CGM system. We can either use it in a retrospective way or in a real-time fashion. Several CGM devices are currently on the market. The most common are shown here. But it's important to consider that all CGM devices are currently formally licensed only for patients with diabetes mellitus. The specific indications, features, and also age limit may vary according to the specific CGM device. Most of our current knowledge on CGM is derived from diabetes. This is one of the first studies collecting data on the use of CGM in diabetes. And as you can see, patients who were monitored with a CGM device showed a decrease in their glycated hemoglobin level. That is one of the traditional monitor parameter in diabetes. Additionally, one subgroup, the adult group, which is shown here, also showed more stable glucose levels. This was not the case for the two younger groups, and for this specific study, the authors related this difference to the lower CGM use in the younger groups as compared to the older groups. Based on these findings and also subsequent evidence, standardized CGM outcomes have been defined for diabetes. These outcomes are shown here, and among them you can see glycemic variability, time above range, time in range, and time below range. For these targets, outcomes, targets have also been defined, meaning optimal targets to be reached in patients with diabetes, which are shown here. And these targets are currently used in clinical care to help any treatment decision. Evidence on the CGM use in hepatic glycogen storage diseases has also accumulated over the past years. In this graph, which is from one patient with GST1, you can see how the use of a CGM device is able to detect otherwise unrecognized hypoglycemia. In addition, the use of a CGM system also allows to calculate the amount of time which is spent in hypoglycemia during the day. This calculation can be done either for the whole day or for specific time frames within the day, as is shown here. And in this study, this calculation was performed not only in GSD1 but also for other GSD types. This is an example of how CGM use can also show the effects of dietary intervention on the glucose homeostasis in GSD. This is a GSD1A patient who underwent several different nutritional treatments, and you can see how the CGM derived outcome parameters allow us to assess the effect of each nutritional regimen on the glucose homeostasis. Still, there remain several open issues to be solved. Particularly, there are no defined CGM-derived outcome parameters for conditions other than diabetes, and similarly, there are no reference values for such outcomes in conditions other than diabetes. Also, CGM accuracy is lower in the hypoglycemic range, which may be a burden for conditions associated with hypoglycemia. And also there is a lack of interconnectivity among different CGM devices. Additionally, there is a strong need for hypoglycemia prediction, particularly in those conditions where hypoglycemia is one of the major symptoms. And finally, but not less important, there are reimbursement issues. As I mentioned previously, at the moment, CGM devices are only licensed for diabetes. In order to tackle at least one of these issues, we have collected CGM data from a cohort of individuals with idiopathic ketotic hypoglycemia. In this table, data from individuals aged 0 to 6 years are shown. Besides the days of recording and the reason for starting a CGM recording, the descriptive outcomes and the parameters of glycemic variability are shown for each individual. By pooling all these data, we were also able to calculate the mean value and also the reference target defined as 95% confidence interval. And this calculation allowed us to identify those individuals whose values diverged from the calculated reference values. We were able to make such comparison not only for descriptive outcomes and outcomes of glycemic variability, but also for time below range, time in range, and time above range, as you can see in this other table. The reason why this is occurring and the clinical relevance of this finding we are still working on. Based on these results and on the open issues that I've mentioned, of course, future directions can be anticipated. Of course, reference ranges for CGM outcome parameters should be developed for idiopathic ketotic hypoglycemia. Ideally, hybrid monitoring protocols can be developed, for example, by a combination of CGM and continuous ketone monitoring. It's crucial to license CGM devices also for disorders other than diabetes. It's also crucial to harmonize data management applications among different devices in order to facilitate data sharing among clinical centers. And finally, based on the refinement of machine learning, the development of algorithms allowing hypoglycemia prediction can be anticipated. Among these future directions, I would like to focus specifically on one, which is continuous ketone monitoring. So recently, a paper has been released in which the accuracy of a continuous ketone monitoring system was assessed, both in vitro and in vivo. In this first graph, you can see how a strong correlation was found between capillary ketone concentrations measured with a standard device and sensor-measured ketone levels. Additionally, in vitro experiments also assess the accuracy of the sensor over 14 days. In this experiment, the sensor was incubated with a fixed concentration of beta-hydroxybutyrate around 8 millimole, and you can see that the accuracy stays stable over the whole recording time. Based on this data, a vivo experiment was also performed on 12 subjects, of whom 11 individuals with diabetes and 1 without diabetes. All subjects were on a low carbohydrate diet. Again, you can see a strong correlation between the capillary ketone concentrations on the x-axis and the sensor measured ketone concentrations on the epsilon on the y-axis. And here in this table, the overall data were pooled. You can see that although the percentage of time in which the difference between the two systems was below 30% was around 90%. The overall difference between the two systems was above 14%, which is still way higher than the difference which is currently found in CGM devices, meaning that further refinement is needed for this system before it can be translated into clinical care. Still, last January, Abbott company announced that actually a continuous ketone monitoring system is being developed, so we can expect this to be available on the market in the near future. And I would like to thank you for your attention.
Welcome back. We have just listened to Dr. Rossi present the role of CGM and also the role of continuous ketone monitoring in children with ketotic hypoglycemia. This is a topic that touches many families from all over the world who urges for their children to get a CGM. A continuous ketone monitor would change the whole game of living with idiopathic ketotic hypoglycemia, so we are waiting with eager to hear more news about this from Abbott. I want to just say a few words to those who have just recently tuned in on our YouTube channel. If you can see the QR code on the screen, it's because we are raising funds for the first PhD in Ketotic Hypoglycemia International. Also, don't despair if you don't have time to stay throughout the whole conference. If you remember to subscribe to our YouTube channel, you will be able to rewatch all of the presentations from today and also all of the Q&As. So please subscribe and continue to learn more about idiopathic ketotic hypoglycemia. Now we're moving forward with the second patient story of today. We are going to hear the story about the Perk siblings.
My name is Lane and I've got 5 amazing children. Over the years, we have battled with ketotic hypoglycemia. It's been different for all of them. With my eldest child, Paige, she used to wake up in the mornings and just be sick. Her heart used to race, just by default really. I used to give her a sugary drink because that's what you do when you feel sick. And we'd get an appointment and go to the doctors, and by the time we got there she was absolutely fine, nothing wrong with her. This happened many times for Paige and we didn't really realise what was going on. I thank my instincts for giving her that sugary drink each time and managing her, and I'm also grateful that we had no huge crashes when she was younger. Then when my second child came along, Connie, Connie was born with complex special needs. Connie was born blind through albinism. And she was thought to have a syndrome, but it was unsure which syndrome she might have. She later on was found to be autistic, and the syndrome, when she was 10 years old, was found to be Noonan syndrome. Prior to that, Connie wasn't very well all of the time, and when she had episodes of illness, there was one in particular I'm thinking of when she was sort of 5. She had a tummy bug. Everybody else had it 24 hours. Everybody else was much better. And Connie took nearly 2 weeks to recover from that tummy bug. And in hindsight, I think her sugars were probably low. And she spent a good 2 weeks, the majority of that on the sofa, not very much energy. And I was always reassured, oh, it's because she's got these syndromes going on. So when my third daughter was born, Pepper, it was when she started weaning off the breast, when she got to about 2 years old. She would have these episodes in the morning where she was just totally unrousable. And my instincts again told me that she needed something sugary, and I tried to give her a sugary cereal, and she'd have her face on the table and she wouldn't be able to hold her head up to scoop the breakfast in. And we were under a paediatrician anyway because my children have complex needs, and this was apparent from early on with Pepper as well. And I mentioned it to the paediatrician. I said, you know, she has these episodes usually in the morning, although they can happen in the day, where she's just really lethargic and not really what you'd expect a 2-year-old to be like. And he said, next time it happens, just ring us and come straight in. It's a 10-minute drive. So we did that, we went in, and they thought, well, maybe it was a seizure. So we went down the route of having EEGs, MRI scan under anaesthetic, and a multitude of tests before we came to the realisation that what she was having was a low blood sugar. Unfortunately for us, one day when she had the EEG wires all over her head, she had a really scary low of 1.6. The ambulance came, checked her sugars, and I can't tell you how scary that was. When you leave the hospital, or if you have a home birth, and you get your baby in your arms for the first time, you think, wow, this is precious, this life I've been entrusted with, and that's daunting enough. And when you have children that randomly drop their blood sugars for no reason, or sometimes there is a reason when they're unwell, the pressure that puts on a parent and the family is enormous. Because Pepper had the hypo with all the EEG leads on, that meant we could rule out that it was epilepsy. From then, we were referred to multiple hospitals in the UK to see specialists to rule out all of the big conditions. We had controlled fasts, we had more admissions because her blood sugars would drop. As you can imagine, for a family, it really throws a spanner in the works. Somebody has to look after the other children. It's a whole day of sitting in the hospital where, you know, worrying, panicking. Are my babies okay? What happened next was I had another baby, and when he started to slow down with the breastfeeding, he was about 18 months, he started having some really scary lows as well. Just out of nowhere, you could just see that he was dropping. And in fact, one morning, I had 3 of my children all have a low blood sugar, which led me to the realisation that mashed potato for tea was not a good thing to help them carry their blood sugars through. So my son Sullivan, he started to have hypos, and what that meant was he needed the same controlled fasts, he was seeing the same doctors. So both of my children were being examined and tested for a number of scary conditions that fortunately they didn't have. Every time we went into hospital with the children, I'd find that nobody really knew what was going on, and it would be put down to, oh, they're poorly, oh, this, that or the other, and I didn't really feel heard for a long time. My son Sully, when he was about 2.5, he slipped at home and he bit through his tongue. We got an ambulance into A&E because my children have issues with their blood clotting properly as well. We got to A&E, we were there 2-3 hours, and they said, right, we will do surgery on his tongue and you can come back tomorrow. And I said, no, he's not going to eat. Oh, he can eat this evening. I said, he will not eat and his blood sugars will not maintain. We need to be here. And I had to insist that we were admitted to the ward. We were admitted to the ward, and I still wasn't taken seriously when I asked for my son to go on a drip with the dextrose, and it didn't happen. And they tried to reassure me and said, oh, it's very unlikely that his blood sugars are going to drop, and they kept coming back every 2 hours to check his blood sugars, and lo and behold, he crashed. He crashed in a big way, which was a shock to the staff at the hospital, but not to me. So we managed to then get a cannula into him and get him the sugars that he needed, and he recovered. Then he had to go for surgery. And then the next 24 hours, again, while he was getting to grips with using this new tongue, he struggled to eat and he needed to remain on that cannula to give him those sugars. By this point, it was a weekday and my usual paediatrician was back in the hospital, and I was able to say, this is what we need to stay another night. And he said, absolutely. And just having that one person that really listened to what I knew my son needed was really very helpful and reassuring. And because nobody wants, believe me, no parent wants to sit in the hospital for overnight, have their child cannulated. You just don't want that unless it's what they absolutely need. Fast forward to now, I have a 3-year-old daughter called Etta, and we thought we'd escaped the hypos with her. No. Still breastfeeding at the moment, and we're coming to the end of that breastfeeding relationship. So again, it's the third, I feel like it's linked for my children with them coming to the end of their breastfeeding, that they're feeding less at night and I don't have to carry them through.
What do you want, Etta? Do you want a boo-boo?
So twice now we've had to get ambulances to hospital with Etta, where she's crashed silly low, and it's been really scary going right back to the beginning. And I know what I'm doing with my children. I know how to manage the hypos, but just because I can manage her doesn't mean that she doesn't have the right to be looked over by a health professional. So making sure that she was safe was a priority in getting her to the hospital. And now we face her going through the same battery of tests. Although I'd like to think that I've got enough about me to say, what she needs going forwards. There must be something, a genetic link that means that all 5 of my children have had regular low blood sugar issues, and they don't appear to be growing out of it. My children now are Paige, 20. She still gets migraines. She still has episodes of low blood sugar if she doesn't eat in time. I have Connie, who is nearly 16. Last year she had a hypo when we were camping. Connie has had several operations, and it's been tricky getting people to understand that she needs her blood sugars looking after. Post-op can be a real problem, especially when my daughter Connie has giant cell lesions of the mandible. She needs a biopsy of those, and afterwards, after that surgery, her blood sugars kept dropping, and she couldn't eat because she was in too much pain with her mouth. Really, really challenging times. This summer, Pepper had a hypo. She was 2.2, and my son, he still has them. Pepper's 13 and Sully's 10, and they both still have hypos. I have to make sure that they eat every couple of hours at a minimum, that they have a good meal in the evening, and this is complicated by the fact that my middle 3 children, Connie, Pepper and Sullivan, all have autism, and they have ARFID, which is avoidant restricted food intake disorder. So it means that we are very limited in what they will eat. And again, it's a lot of pressure as a parent to make sure that your child eats, because you don't know what could happen in the morning. Sullivan and Pepper have both had anaesthetics for things as well, and you almost have to be really, really pushy that your child needs to go on the list to go down first, because, and it's not because we don't want to wait around, it's because I'm worried about their safety. Even just general childhood illnesses like the chicken pox have thrown us huge curveballs. Pepper had all in her mouth, on her gums, and she could barely eat. To go into hospital with a child with the chicken pox because they're not eating, for 9 out of 10 children, not a problem, their body will carry them through. But with a child like mine, where their blood sugars don't regulate, it can be really serious. There's a photograph of Etta lying on the floor, and it always makes you wonder, when they just drop to the floor like that and fall asleep, somewhere that you think that's not comfortable. The first thought is, are they having a low blood sugar? And as they grow, and you need to send them to nursery and school, you have to hand over that responsibility for them, which again is huge, because people aren't going to know your child like you know them. I can take one look at my children, or have one smell of my children and go, right, okay, we're going to get the monitor out and we're going to check your blood sugars. And 9 times out of 10 with the older ones now, unless they're unrousable, we don't really tend to check. We just tend to just get more snacks in, just try and do what we can to manage them, more based on their symptoms than their numbers. Because we were also finding that, especially one day we went to see the endocrinologist, and Pepper, she absolutely slumped to the floor and she was not right, and the doctor insisted we check her blood sugars. Now they were around, I'm sure they were 4.5, something like that. But symptomatic wise, she was having a crash. And is that because her blood sugars dropped really quickly? We don't know. Had they been at 7 and suddenly dropped to 4.5? There's no rhyme or reason to any of this for us. So we just tend to treat them based on their symptoms. As a family, when you have children who don't manage their blood sugars very well, it was brought to our attention one evening in a heat wave by going down to the river and throwing some stones in the water and playing after dinner in the evening, that the next day 2 of the children had low blood sugars, and that it's given us that knowledge that my children really can't do anything after dinner, or they need another dinner to carry them through the night because their body will have used up that resource. Ask the parents, listen to the parents, because they will know their children, they will know what works, and they will look to you for the information and support, and encourage them that they know their children and that you believe them. I think my take-home message is that managing this has a huge impact on the children, on the families, and for me, I've been through this now several times with different things, with autism, with Noonan syndrome, and now to Ehlers-Danlos syndrome. One of my children has an official diagnosis of Ehlers-Danlos syndrome. It probably means that all of my children have the same condition. So I know how things work, and hospitals tend to go to the main illnesses to try and rule those out. But when you're a parent that isn't used to knowing this, it's really very frightening. It's very frightening to think your child might have X, Y, Z. It's very frightening to have your child have a low blood sugar and you have to ring an ambulance. And you don't want to waste anybody's time because you know that a little bit of sugar is going to pick them up, but it's bigger than that. And I'm so glad that I've been in Facebook groups for all this time and getting parental support where I've needed it for my children.
Welcome back to the second day in the annual conference of Ketotic Hypoglycemia International. We just witnessed some of the complexities of living with idiopathic ketotic hypoglycemia, listening to the Perk siblings struggle with ketotic hypoglycemia, and also the parents' struggle to be listened to by healthcare professionals. Now we're moving forward with a very interesting presentation talking about emergency protocols, something our families so desperately need to make sure that they are received at the hospital and receiving specialized care. This is a presentation by Dr. Terry Dirks, one of our scientific advisory board members, on an initiative from the Metabolic European Reference Network.
I'm thankful that I've been given the opportunity to share the experiences with emergency protocols and emergency letters for patients with glycogen storage diseases and fatty acid oxidation disorders. I'm presenting on behalf of many colleagues and patient representatives who have been collaborating in the last decade. I would like to share with you that this is more than a project, and that ideally it should be a sustainable process. My name is Terry Dirks. I'm working as a metabolic pediatrician at the UMCG in Groningen in the Netherlands. For this presentation, I don't have any conflicts of interest. First of all, I would like to thank our patients with whom we are continuously building experiences and improving our care. During many patient organizations meetings, I've been inspired by families who have shared their stories about acute hospital admissions. Sebastian de Boekhorst is the father of 2 boys I know from our clinic, who, as an ICT specialist, has been responsible for the software development. Hanke Dekker is the director of the Dutch Patient Organization for Metabolic Diseases, with whom we have developed and hosted the website www.emergencyprotocol.net. And we will continue on this journey together. Without money, no projects. I'm very thankful to the funders and in particular UMCG for their MD-PhD program. It's a pleasure to work with PhD students such as Irene Hogeveen, Fabian Peaks, and Alessandro Rossi. The last step would not have been possible without EU funding on behalf of MedHub-ERN. This is the European Reference Network, in which we closely collaborated with international metabolic centers. During several meetings in the last decade, colleagues have participated in workshops and shared their valuable experiences with regard to how they apply emergency protocols in their clinics. This slide is summarizing some additional critical moments and milestones in the development of the website. Together with Sebastian de Boekhorst in 2014, we started digitalizing our process in generating the emergency letters. We were able to translate this clinical experience into a simple algorithm which reduces the chance of making mistakes. We incorporated practical clinical experiences that we gained in the subsequent years and that we have exchanged with healthcare providers during conferences. In some of these steps, our master students and PhD students actively contributed. We learned during patient meetings and focus group meetings that this is also a topic that really matters to families. The question, how should sickness and emergency situations be managed for patients with liver GSD, was recently prioritized in the International Priority Setting Partnership in collaboration with the James Lind Alliance. The subsequent INEA project's money allowed us to disseminate the protocol to other centers and internationally. During the pandemic, as part of this MITAP ERN eHealth project, we were able to meet the colleagues digitally to improve the emergency protocol and to launch the website. The website was introduced in June 2020, and the scientific article was published quickly thereafter. We retrospectively described the outcomes of acute hospital admissions in 128 patients representing over 470 so-called emergency protocol years. We found that in our hands, this protocol was very safe to work with. In brief, the emergency protocol describes two phases. Phase 1 can be executed by families at home when the sick dietary regimen is not well tolerated. Regular oral rehydration salt, ORS, does not contain enough calories and carbohydrates for metabolic patients. Therefore, this protocol makes use of an emergency solution that consists of maltodextrin added to an ORS solution. The amount of maltodextrin depends on the body weight. The estimated calculated carbohydrate requirements per kilogram body weight are based on experimental data derived from stabilized dose studies. The volume of the emergency solution meets the fluid requirements. Analgesics are advised for fever management to reduce energy demands. It is important that families know when to call and whom if there is no clinical improvement in phase 1. Phase 2 is executed in the emergency department or initial hospitalization, controlled by healthcare professionals, before expert metabolic support can be requested. Phase 2 occurs usually not in a metabolic center, but in a local hospital. The emergency letter lists the ideal minimal laboratory tests required to assess the metabolic status of the patients in the first critical sample. For a patient with GSD1B, these tests are blood glucose, blood gas analysis, lactate, neutrophils, and blood. In case of a patient with VLCAT, neutrophils would not be of importance, but CK and myoglobin would be added instead. Phase 2 ends with consulting the expert metabolic center and does not replace disease-specific in-hospital expert metabolic treatment. Having an emergency letter and knowing how to use it can prevent life-threatening situations and will optimize the communication between parents and different healthcare providers. The website offers the necessary information to generate an emergency letter for an individual patient. It has the goal to improve the initial care for metabolic patients during sickness at home and the first evaluation phase in the hospital to prevent metabolic emergencies before proper metabolic treatment can be started. From the main page of the website, the link leaflet contains information leaflets for families in several languages. We advise not only families and parents, but also healthcare providers who want to generate an emergency letter to carefully read this practical information and to discuss it together. Some items may be less applicable for a local situation. The page Emergency Letter allows you to generate an emergency letter. First, we carefully need to read the following information. This information is important. Each emergency letter needs to be checked by the person who generates it. After accepting these terms, one can continue to generate the emergency letter and the next page will automatically appear. After filling in the name, the date of birth, and body weight, you need to fill in the exact diagnosis. Emergency letters can also be generated in several languages. This allows to generate an emergency letter for normal situations, but also for holidays in a foreign country. It is crucial to discuss with your metabolic expert doctor, geneticist, or GSD specialist how they can be reached by local healthcare providers. This is differently organized by different hospitals in different countries. For some metabolic centers, we already included their contact details in our database. This information will automatically appear in the emergency letter. In many cases, the metabolic center is not the first hospital close to where the families live. So it should be well communicated who is the first point of contact for the families to prevent unnecessary delay. Here you can fill in these contact details. After pushing the Create Emergency Letter button, the emergency letter will be generated either as a PDF file, Word file, or HTML. Until very recently, over 1,600 emergency letters have been generated in these languages. As you can see from the next slide, most of the emergency letters have been generated for patients with MCAT deficiency and GSD1A. So where are we going to? We are undertaking several actions to disseminate this emergency protocol. We think it is important to add missing languages and disorders. For instance, some fatty acid oxidation disorders are still missing, and we find it a top priority to add idiopathic ketotic hypoglycemia to the list of disorders too. The landing pages of the website should be translated into the different European languages. On the longer term, it will be important to work on stronger consensus guidelines using, for instance, the Delphia method to find agreement on the emergency regimens. Finding a partner for sustainable production of a standalone emergency solution product is also very important. Also, we would like to develop tools to improve the communication between families, local healthcare providers, and metabolic specialists. I thank you again for your attention.
Welcome back to the second day of the annual conference of Ketotic Hypoglycemia International. We have just listened to the Scientific Advisory Board member, Dr. Terry Dirks, talking about emergency protocols. Before diving into the first live Q&A, we are now going to listen to another Scientific Advisory Board member. This time we are listening to the UK doctor, Dr. Pratik Shah, who is going to talk about signs and symptoms in idiopathic ketotic hypoglycemia.
Hello everyone. Thank you very much for inviting me. I'm going to talk about signs and symptoms of ketotic hypoglycemia in children. I work as a consultant pediatric endocrinologist at the Royal London Children's Hospital, Barts Health NHS Trust in London, and my research is based at Queen Mary University of London. So when we talk about hypoglycemia was actually first reported in 1922 by James Collip when he was purifying insulin. And it's actually 100th year when the hypoglycemia was discovered. When we talk about hypoglycemia in children, it is really important to make sure that we interpret plasma glucose concentration in association with the presence of risk factors, the clinical examination of the child, and the intermediary metabolites and alternative fuels that are present at the time of hypoglycemia. And it's also very important to remember that an individualized approach may be needed to manage children, taking account into patient safety as well as family preferences. And when we talk about signs and symptoms in children of hypoglycemia, they are actually age related. It depends on the age of the child and how frequent the hypoglycemia is. And it's been now nearly 50 years since it was first reported that what are the adverse outcomes of children of hypoglycemia in children. And over the last 50 years, there's been numerous published reports about the hypoglycemia and its implications on neurodevelopment in children. And hence, it is really important to recognize the signs and symptoms of hypoglycemia in children. When we talk about the causes of hypoglycemia in children, there are numerous causes of hypoglycemia that has been reported, and the list actually goes on and increases. When we talk about ketotic hypoglycemia or non-ketotic hypoglycemia, and recently, there are several genes reported for possible causes of idiopathic ketotic hypoglycemia, and the research actually still continues. And there are lots of research being undertaken to understand the genetic etiology for idiopathic ketotic hypoglycemia. And there are other causes of hypoglycemia in children, like counter-regulatory hormone deficiency in children, like growth hormone deficiency or adrenal insufficiency, defects in ketone body synthesis and utilization, like gluconeogenic disorders, which we would say GSD type 1 or fructose 1,6-bisphosphatase deficiency, glycogen storage disorders, defects in glucose transport, or other metabolic conditions like galactosemia, hereditary fructose intolerance, adenosine kinase deficiency, or mitochondrial respiratory chain disease. Obviously, the more common we come across in children for hypoglycemia or ketotic hypoglycemia is like infections, when they're present with diarrhea, vomiting, or respiratory illness. Sometimes liver disease or drugs can also induce hypoglycemia. And now there has been an increased number of syndromic conditions that are being recognized that can cause ketotic hypoglycemia, where like Kennan-Lenz syndrome, which we reported as 2 children in the family having ketotic hypoglycemia, Costello syndrome, Down syndrome, Russell-Silver syndrome, Kabuki syndrome. There are other conditions like fatty acid oxidation disorders. And we also have non-ketotic hypoglycemia, where we look at as hyperinsulinemic hypoglycemia, which could be either transient or congenital forms. And there was a report about hypoinsulinemic hypoglycemia. Again, this is a hypoinsulinemic hypoketotic hypoglycemia, which is due to activating AKT mutations. So what it suggests is that there are numerous causes of hypoglycemia in children. And when we talk about mainly ketotic hypoglycemia, there is a lot of research being undertaken right at the moment to understand the genetic etiology. And it's very important that actually the signs and symptoms can vary depending on what condition the child has. So why do we need to know about the signs and symptoms of ketotic hypoglycemia? And the questions are, do children always have signs and symptoms of hypoglycemia or ketosis? And actually, not really. They don't necessarily have the symptoms or signs all the time. And why is it then important to know? And the reason why it is important to know is because hypoglycemia, as we know, it's a medical emergency. As I've described earlier, that it's been now more than 50 years where there have been numerous publications about the hypoglycemia and its impact on neurodevelopment. And it's important to recognize to this condition quickly and to manage the children quickly, so that actually we are able to prevent the complications of hypoglycemia on children. But also, it's important to carry out necessary investigations. So when the children present with hypoglycemia, you take critical samples of hypoglycemia screen, which will help us to evaluate the cause of hypoglycemia. And as I mentioned, this has got a short-term as well as long-term outcome on children. So it's really important to understand the signs and symptoms of both hypoglycemia and ketosis, and remembering that children may be asymptomatic when they come to hospital. So when we talk about signs and symptoms, as I mentioned earlier, they could be age dependent. So children would have different signs and symptoms depending on what age they present. It also depends on the frequency of hypoglycemia they have. If they have frequent hypoglycemia, then they may be asymptomatic because they are able to function, their brain is able to function at a much lower glucose levels, and they may not necessarily have symptoms. The same things happens with ketosis, and if they obviously have been mounting ketogenic response or having high ketone levels, they may not necessarily have symptoms at reasonably higher ketone levels, and hence it is really important to recognize the symptoms. It also is important to look into history. So when children present to hospital in A&E department, we also have to remember what are the other presenting complaints, where when they've presented with fever, diarrhea, vomiting, have they got any underlying illness that is actually causing them to have hypoglycemia. And as I mentioned, that it's really important to think about other causes, and when you look at the general examination or systemic examination, they may have some syndromic features. So there has been now increased number of syndromes that are being recognized that can cause ketotic hypoglycemia in children, and we reported two siblings with Cannon-Lenz syndrome who presented with mild idiopathic ketotic hypoglycemia. There are other syndromes that have now been reported that can cause ketotic hypoglycemia, like Down syndrome, Russell-Silver syndrome, Costello syndrome, and Kabuki syndrome. So now we're going to talk about signs and symptoms of hypoglycemia. And as I mentioned, children can be asymptomatic or they may have non-specific symptoms of hypoglycemia. And it also depends on the age at the time that they're present with hypoglycemia. So the symptoms can vary, like hunger or poor feeding, sweating, lethargy in babies or very young children. And older children can then present with weakness or tiredness. They can complain of palpitations or fast heartbeat. They can have change in color or shakiness, tremors, or unsteadiness while walking, or they may complain of having blurred vision or headache or poor concentration at school. Sometimes they can also complain of dizziness, confusion, and change in behavior. And rarely they can have apnea or loss of consciousness or seizures, and rarely death. So it's very important to think about any non-specific symptoms can cause hypoglycemia, and monitoring blood glucose is really important in conditions that may cause hypoglycemia. And then next we will be talking about the signs and symptoms of ketosis. And again, as I mentioned, that if they have frequent high ketone levels, they may be asymptomatic. However, children can present with acutely with when they have ketosis, with nausea, vomiting, abdominal pain, muscle cramps, headache, lethargy, and sometimes in more severe cases they can have coma and polypnea, which is Kussmaul's breathing. And also they have characteristic aromatic smell on the breath, which is due to acetone. And if it is not treated or recognized early, then they can develop ketoacidosis, which is an emergency condition, and we need to manage it promptly. And also, children, if they are not recognized having ketosis and for a long time, then the chronic ketosis actually can lead to weight loss, poor appetite, poor growth, elevation of liver enzymes, and osteoporosis. So these are all recognized complications of chronic ketosis. And again, this highlights that how important it is to recognize this condition, because children can present with this signs and symptoms, and it has got implications on their long-term health. So thank you very much for listening to me, and would like to thank patients and families, my colleagues at Roland Children's Hospital and Queen Mary University of London, as well as those colleagues who I collaborate in the UK as well as internationally, and the various family organizations who I work with. And now I'm ready to take on any questions if you have.
Welcome back to the second day in the KHI conference. We just listened to Dr. Pratik Shah talking about the signs and symptoms of idiopathic ketotic hypoglycemia. I am so pleased to now welcome to the first live Q&A with our experts, and I'm here welcoming both Paul Thornton and Dr. Pratik Shah to this live Q&A where we are ready to answer questions from the audience. Welcome, Pratik. Welcome, Paul.
Daniel.
Thank you.
Nice to have you here again today, and thank you for being so active on the YouTube chat. It's like a long Q&A throughout the whole conference. Thank you so much. I am now ready with a lot of questions, and I will start with the first one directed to Pratik. What if my child isn't symptomatic, but her numbers are either low with the blood sugar or high ketones? How can this happen? The doctor says it must be errors on the meter, but I am always checking with 2 different meters.
So I think we discussed this yesterday as well, and Paul very nicely explained as well that what we do know that children, can have asymptomatic hypoglycemia, and what happens is if they have recurrent or persistent hypoglycemia, then their brain actually is functioning at a very low levels of blood glucose levels, and hence they may not have any signs or symptoms. And obviously, if they are not treated and if they have left for long in terms of hypoglycemia, then they obviously can develop severe symptoms, which is having, fainting episodes or even seizures or going into coma. I think one of the things which we just need to be mindful, like the parent has mentioned, I think obviously you check with the glucose meter just to be absolutely sure that it's a true hypoglycemia. However, yes, if you check with different meters and making sure that the technique and everything is correct, then most important thing is to speak to your clinician, and taking a lab glucose and confirming that this is actually a true hypoglycemia, if any doubt.
Thank you so much, Pratik. And I will continue to the second question, this time for Paul. How do I keep my child safe when we have been told not to test the blood sugar or ketones?
Yes, well, that's always a difficult one. And I think, the first question I would say is to ask the physician, why do I not need to check my blood sugar and my blood ketones? Because remember, there are various degrees of severity, and it could be that in one person's case, the child only develops hypoglycemia after very prolonged periods of fasting, in which case we would recommend checking the blood sugars and ketones if your child has an intercurrent illness. But then there are other cases where children develop hypoglycemia and ketones within 6 to 8 hours of fasting. And in that case, they do need to check. So what I would try and do is understand on what basis did your physician make that recommendation. And then if the basis sounds legitimate to you, that's probably fair. And if the basis is that he just doesn't know, then that's where you need to get another consultation and perhaps see a different physician to determine exactly, what the nature of my hypoglycemia is, so that therefore you can put the correct plan in place to fix the problem.
Thank you so much, Paul. And diving into another question about being symptomatic. Why am I told my child shouldn't be symptomatic at 3.7, but he is? Are there no consensus around this? It seems like doctors are saying so many different things. Pratik.
Yeah, so it's a very difficult question to kind of answer. I think in terms of we do see sometimes children may be symptomatic in high threes, which is about 3.7, so if it's about 68 or 69 milligrams per deciliter. But I think more importantly is that, if the child is symptomatic in high threes, then yeah, that means that if you need to, you can always treat it. But we have to discuss with the clinician as like what is the cutoff as they what would consider to treat the child. But the fact that if they are symptomatic, and obviously if you leave them for long, then they can drop their blood glucose levels. So hence it's in a way important to monitor, because they are getting symptomatic in high threes. So it's important that you discuss with the clinician to see where, obviously, if your child needs treatment, and at what number, and how do you really manage those if they are getting symptomatic.
And Paul?
Yes, I'd also like to add that we have to remember that the symptoms of hypoglycemia are vague and non-specific, meaning that you could be hungry, which is a symptom of hypoglycemia, but you can be hungry because you're hungry.
Yeah.
And you can be tired, which is a symptom of hypoglycemia, but you can be tired because you're up all night. So one of the things we have to try and do is determine if the symptoms we're having could be caused by something else. So as a general rule, I think you'll find that most physicians will say that if your blood sugar is normal and above 3.7 or 8 is normal, 70 milligrams per deciliter in the US, then they would say that the symptoms are typically not due to hypoglycemia. However, there is a caveat to that, and that is that the neurogenic symptoms, which are the first symptoms that people perceive before they start suffering from brain dysfunction, can also occur due to a rapidly changing blood sugar. So if your blood sugar drops from 150 down to 70, you could get those symptoms of hypoglycemia because that's your body secreting adrenaline or epinephrine to prevent the blood sugar going lower. So generally what I say to our families is that if we have a well-defined hypoglycemic disorder, then we can check when there are symptoms. If the blood sugar is not low, then we're not in a panic situation, but do the things that you need to do to make your child feel better. But, this is not a panic. I don't have to rush to the emergency room. This is just, let's feed the child and see do they do a little better. So there are a lot of complex things about that. But that's the background as to why doctors will often say that if your blood sugar is normal, it's not the cause of the symptoms.
Thank you so much, Paul, also for elaborating on this. I have a question for Pratik. What is considered chronic ketosis? My son always has ketones when I test his blood ketone. When healthy, they are under 0.5. Would chronic ketosis be above that when not sick? Or what is categorized as chronic ketosis?
Yeah, so I think we would generally say under 0.6 is okay. It's absolutely fine, and it depends on obviously how much ketones they obviously go into. But like we discussed yesterday, like we've had people reporting that they have ketones up to 7 or 8, which is very, very high. But we would generally say, look, it depends on the when the ketones are produced. So whether is it due to the fasting, or is it at the time of illness, or is it when the child has got ketones in a fed state? So that means when they're eating normally, and are they still having raised ketones, which would be generally be say about 1 or 1.5, at least about 1.5, and that means that needs investigations, because if they are having raised ketones even when they are fed regularly, then that would need investigations looking into what it is. However, if there is occasional raised ketones, which is at the time of illness or at the time of prolonged fasting, then that would kind of say, okay, the ketones are getting back to normal. So it depends on how long when the ketones are actually raised, the duration, and does it actually come back to normal. And that is obviously will then depend on, which would say that if they have continuously raised ketones, that's when we would expect them to develop more effects or signs of chronic ketosis.
Thank you,
Yeah, and
Pratik.
if I could add to
Yes,
that, Danielle,
of course.
we have to remember that ketones occur because our body doesn't have enough glucose for fuel. So when you have elevated ketones, it usually means that your body is not producing enough glucose. But it can also occur when you are unable to use ketones. So one of the tests that we do that Dr. Shaw talked about is we would bring the patient into hospital and either feed them or give them IV dextrose to see can we suppress the ketones. And if the ketones are able to go down below 0.3 millimolar, then that proves that it's not a ketone utilization defect. And so sometimes that's why your doctor will want to bring you into the hospital and maybe put you on your usual home feeding protocol. And if that doesn't suppress the ketones, then try intravenous glucose to give us a clue as to whether the problem is that the body can't use the ketones and therefore they're never able to get out of the blood system.
Thank you so much, Paul, for elaborating on this. And I think I have a question in line with this. It's a little long, so hold on tight. I would like to know the effects of persistent long-term hypoglycemia, the causes and possible triggers of reactive hypoglycemia, and also the effects of hypoglycemia in relation to brain infarction, stroke, and focal seizures. Wow, that was a big one.
That's the whole conference.
Yeah.
That's all. Exactly. I think you kind of asked the question about
Great. Who wants to take that?
Yeah, let's break it down bit by bit and let me address the issue of postprandial meal hypoglycemia. So this is something that should in the general population be very rare, that your blood sugar drops low after you eat. But there are circumstances in which it does occur very commonly. So children who have G buttons and who've had J tubes and who've had Nissen fundoplications, who've had surgery on their intestinal tract, are at much higher risk of postprandial hypoglycemia. So the general rule of thumb is that when someone comes in and says that I get low blood sugars after I eat, the first thing we do is look at their tummy to see do they have a G button or a scar from gastrointestinal surgery. Now, there are some medical conditions like glycogen storage disease type 0 where your blood sugar goes high and then drops low. And there are some conditions where protein will trigger a low blood sugar. So it's important that your doctor takes a good history, tries to understand the timing of the blood sugars after the meal, and then, if necessary, do a special test in the hospital whereby they can give you a high carbohydrate load and see does your blood sugar drop down. For most people who have simple, what's called reactive hypoglycemia, it is an inconvenience and doesn't cause harm. So the blood sugar goes high, swings down low after the meal, they feel bad, and then it pops back up on its own. For most of those people, the secret is to avoid high carbohydrates in your diet and you can reverse the problem. So just breaking down one of those four pieces, and I'll let Pratik address the next one. And then I'll take on another one of the four things you asked.
Thank you so much. Pratik, here you go.
So now I need to remember, was the causes of hypoglycemia? What was one of the questions?
Yeah, the causes and possible triggers of reactive hypoglycemia. So I think that's what Paul talked about. But the effects of persistent long-term hypoglycemia. Maybe you will take that one.
Yeah, okay. So I think obviously we need to look at the causes and what is the cause of hypoglycemia. We're talking about idiopathic ketotic hypoglycemia, and what we discussed yesterday. I think there is this what we expect is ketones to protect the brain, And this is what the whole situation is when we think about ketones protecting the brain and as an alternative fuel. However, if there are defects where ketones are not passing through blood-brain barrier, or there are conditions where they are not able to utilize the ketones, then yes, they possibly, we need to look into what will be the impact of long-term hypoglycemia on the neurodevelopment. If we are talking about any other conditions, which is obviously not related to IKH, again, that depends on if there are ketones available or not. But what is most important thing is that I think the underlying cause, identifying what the cause is, and then making sure that the hypoglycemias are treated and managed promptly.
Thank you so much, Pratik. And I just got a clarification from the family. They are trying to ask about long-term hypoglycemia and focal seizures. So when I say hypoglycemia and focal seizures, what are you saying then?
Yeah, so hypoglycemia can in itself cause brain damage. So if you have a severe, very low episode of hypoglycemia in the absence of alternate fuels for the brain, either because the brain can't use them or they're not there, then you can sustain brain damage. And that brain damage can then at a later date trigger seizures that can occur both in blood glucose levels or in hypoglycemic levels. So hypoglycemia can cause brain damage, which can then cause seizures later. And so that's important for people to understand.
Thank you so much, Paul. And with these words, I want to thank you both for joining this Q&A. And what we just talked about is very relevant for the patient story you're all going to watch now. This is the story about Bo.
Thank you.
Hi, my name is Sabrina LaField Loomis, and I have a beautiful 7-year-old that's about to be 8 on February 21st named Bo Jordan Loomis. I told my OB/GYN while I was pregnant that I used to have problems with fainting as a kid. I had some odd behaviors that my mom told me about, but I didn't find out until I was an adult in my late 30s that I actually had problems with my blood sugar dropping. So we weren't surprised, or they weren't surprised when I had gestational diabetes, but that was the only thing, and we monitored it while I was pregnant, and everything seemed to be fine. I actually ended up being in labor for right at 3 days. They tried to induce me and nothing was happening. It had already been 2 days. I just, I didn't feel right for being in the hospital for 2 days and not moving, sitting in a bed. I shouldn't have been feeling the way I was feeling and feeling just kind of lightheaded and out of it. And they said, no, don't worry about it. We checked your blood sugar when you first got here. And I'm thinking to myself, that was almost 2 days ago. And they still kept blowing me off, and they actually started talking about having a C-section. Just a little while after eating, I actually started dilating and going into labor, and then they're telling me, don't push, he's about to come out. So he ended up coming out, and the rest was fine. And for the first part of his life, he just seemed to be a happy, just wonderful little boy. Because I had known about low blood sugar, and me being a mom with low blood sugar, I was concerned about him, and I asked his pediatrician, hey, should we be checking his blood sugar? And she's like, oh no, nah. And of course, they just kind of treated me as, the crazy first-time parent. And I didn't know how serious at the time low blood sugar could be. All I know is with my experiences as far as behavior, I didn't know that it could actually be life-threatening. I wish I would have pushed further, but I didn't.
Hi, Bobo. Hi, my love. Hi, precious. Mommy loves you. I love you.
So we thought Bo seemed to be developing normally, but then we started noticing that he was a late talker, a late walker, and he started having these episodes. It was only a couple of times, but it seemed to be whenever he was getting the cold or the flu or getting sick. And then when he was about 17 months old, my husband was out of town, and a very dramatic episode happened. Bo and I had just woken up, and we were in the kitchen. He was in his high chair eating, and then all of a sudden he just started getting cranky and crying uncontrollably, and his eyes started having that weird look in them again. And I could see his eyes, he almost was looking up, and I was like, something's not right. He's just crying and crying, and my gut was like, this is not good. He wouldn't stop crying. And all I can say is that his eyes just looked different to me, and they were kind of rolling up just ever so often. And so I just picked him up. I was like, you know what, I'm taking him to the ER. So I grabbed him, took him to the ER. He was still crying and screaming. We waited. They finally took us to the back. They checked his vitals, and they thought, oh, maybe he just has the flu. I think he was running a slight fever. They were just going to send us home with some antibiotics. And I just still didn't feel comfortable leaving, but you know, what am I gonna do? So they discharged us from the ER and sent us home, and I'm literally in the parking lot in my car putting him in his baby seat, and he starts doing this thing again with his eyes rolling back even more severely, just rolling back, and he's crying and he's crying and he's crying, and I'm just starting to panic. I'm like, something is seriously wrong. So I just grasped him up and ran through the ER. I went right past the waiting room and went back to where I knew the doctors were. And I'm like, look, there is something neurologically wrong with my child. You have to do something. Do blood work, do something. And I remember the nurse telling me, well, blood work isn't going to tell us, you know, if there's anything wrong with his brain. We need to do a CT scan. And I'm like, no, do that. Do blood work first, and then you can do a CT scan or do whatever you have to do. But there's something neurologically wrong with my child. Of course, they were reluctant, and they drew the blood work. And we were just waiting, you know, so they could probably do the CT scan after all the blood work came back. And I was sitting there with him. I had already fed him because he seemed to still be hungry. And the nurse comes back with this weird look on her face, and she's like, didn't you just feed him? And I was like, yes. She's like, because his blood sugar was in the 40s. And of course, I didn't know what to think then, and I'm thinking to myself, blood sugar. Yeah, again, the brain has to have oxygen and glucose to function properly. And that nurse just told me that blood work isn't going to tell me if there's anything wrong, anything neurologically wrong with my son. And anyway, the wheels started turning. But they ended up rushing us because, you know, it seemed to be very serious. The doctor actually never came back to speak to me. Didn't say a word. They actually called an ambulance and decided to send us to downtown for more specialists. And they sent us down to Texas Children's Hospital. Long story short, he ended up being diagnosed with congenital hyperinsulinism. And he was 17 months old, almost 18 months old, which is the late diagnosis for this disease. So the first year and a half of his life, he wasn't getting enough glucose to his brain. And who knows how many times in the middle of the night that he wouldn't be getting enough oxygen to his brain.
That's awesome.
I started learning about hyperinsulinism and the damage that it can do. And talking about this is very, very difficult for me. Anyway, Bo's diagnosis, late diagnosis of hyperinsulinism, severely affected his brain. We've been through a lot with him. We've spent our life savings trying to figure out how to help him heal from this brain injury that was caused, that could have been prevented, let's just say that. Yeah, he's done all kinds of therapies. Food therapies, he has major food issues, feeding, eating. Bo has learning disabilities, diagnosed with autism. He is nonverbal, still considered nonverbal at almost 8 years old, but he did start talking and saying words more at 6.
Hey Bobo, what's your name? Yes. Bo. Your name. Yeah, that's your name. That's your name.
He did say mama for the first time when he was 5 years old. I waited so long for that moment. After Bo's congenital hyperinsulinism diagnosis, we knew that it was protocol to periodically do a fasting study as a lot of children grow out of this disease. I knew that he was still having problems with his blood sugar dropping, so I never wanted to do a fasting study and put him through that unless I knew for sure that there was a chance that he had grown out of it. And we had missed doses before and his blood sugars would start to drop pretty quickly, so I still knew that he needed this medicine to survive. It ended up being at the age of 5 when I finally said, you know what, maybe it's time for us to go ahead and do a fasting study and see if he's grown out of this. We were so grateful. They said, Bo, his body is now making ketones. You're gonna be cured of this disease, is pretty much what they say, what they tell you. But I was still just had that little piece of me that said, you know what, let's just still continue to monitor him, which we did at home. We always are very particular about diet. We kept him at a certain amount of carbs, not too little and definitely not too much. He was 6 years old the first time he ever actually had candy. We, tried to keep life as normal as possible and just continue to monitor him. But I actually told the doctor, do you mind if we keep him on, since he's still doing okay? He technically has grown out of this, but it's keeping his blood sugars right where they need to be and where I feel comfortable. Because I still knew once we took him off of the medicine, his numbers would go down lower, like in the 50s and 60s. And the way we worked his diet out and how many carbs he was eating, just this small amount of diazoxide, 1 ml, was keeping him where he needed to be. And he agreed to let me continue, even though he had outgrown that diagnosis, and this was keeping him stable, especially at school, just to keep his teachers comfortable with his numbers. It would just keep his numbers about 20 or 30 points higher, and so we agreed to do that. Where we are now is October 31st. Bo caught some kind of stomach bug and started having these vomiting episodes. I mean, scary vomiting episodes, like he wouldn't stop. I was so afraid. And especially because he does still have to take diazoxide, that we wouldn't be able to keep the medicine down, and we were having problems keeping food down. at first I was like, well, we don't have as much to worry about because his body's making ketones now. That's what I kept telling myself. He's going to be okay. And we checked his blood sugars and they were still like in the, 70s and high 60s for a couple of days because he was vomiting for a couple of days. But it ended up being on the third day he was sick. I woke up that morning, and I looked, and all of a sudden Bo was in bed with me, which never happens. And then I look at the clock, and it's over an hour past his normal time that he wakes up. And I was thinking to myself, something is seriously wrong. This child always wakes up early and ready to go. So I try to wake him up, and he would hardly move. And I holler at my husband, please, we have to check his blood sugar now. We have to check his blood sugar now. This is not normal. And so my husband checks his blood sugar, and he was like, oh my God. And my son's blood sugar was 28, the lowest that we had ever seen before. I remember the fear and just trying to hold it together and thinking, okay, what are we going to do? Before, we used to be able to give him a glucagon, so I don't think it's going to work. So I tried to do it anyway, and it didn't work. My son was like in and out of consciousness. I just decided, even though we had never done it before, please just call 911. I don't want to wait. Please call for help. Because normally if his blood sugar is low, we just take him to the hospital ourselves. But I was in a panic. We called them, and they came up and, tried to see what they could do. And they were actually able to kind of get him awake enough to safely give him glucagon gel, and nothing happened. It only came up to 31. And of course, I'm still freaking out. And I remember the paramedic saying something that no one's ever said to me through his whole hyperinsulinism journey, is that make sure he's breathing, make sure he's breathing. And I'm like, why? And he said, when their blood sugar drops that low, the tongue can swell and block the airway. And I'd never heard that before. So we checked, and of course he was breathing, but I was just like, you know what, give him to my husband. They were kind of waiting around, and I'm a very urgent mother. And so I just told my husband, take him right now, take him to the hospital. And he did. And they ran a bunch of tests, and we now have a new diagnosis. My son was diagnosed at the hospital. They checked his blood work, and with his blood sugar being extremely low, his ketones were extremely high. All they said was they were 10 times the normal amount that they should be. And they ended up diagnosing my son with ketotic hypoglycemia. And I wonder how many years he's actually had this, and we didn't know.
Bobo. Bobo. Hi. Are you okay?
We have to bring awareness and education to more people, especially when it comes to infants. How many of these children are having problems with low blood sugar? I wish I would have known a long time ago the damage that low blood sugar can do to your brain. It's a very easy diagnostic test. Cheap. Please, I'm begging you, if you work in the medical industry, or even if you're just a parent that has knowledge of hypoglycemia, please spread this information. Children's blood sugar need to be checked, especially as infants. Before they leave the hospital, we need to make this a priority. It is a vital sign. You can't survive without glucose getting to your brain. You know, we wouldn't let our children go without getting oxygen to their brain. Why are we letting them go without getting glucose to their brain? Please, I'm begging you.
It's cracking me up.
I know.
He's like,
Welcome back to the second day on the conference in Ketotic Hypoglycemia International. We just listened to the story about the little boy called Bo, who transitioned from congenital hyperinsulinism to ketotic hypoglycemia. And before moving on, I just want to send a big shout out to Bo's parents. I know this video was so very difficult to make, but I also know that you're so proud about the results and you are advocating to save children from suffering brain damage from unexplained and undetected hypoglycemia. Now we are moving forward with a presentation on this matter about transitioning from HI, hyperinsulinism, to ketotic hypoglycemia by our own Dr. Paul Thornton.
Hello, I'm Paul Thornton, back to talk to you again, and today I'd like to talk to you about hyperinsulinism to ketotic hypoglycemia. What do we know? The objectives of my talk are to review the scientific literature about this topic, and then to think a little bit about the different forms of hyperinsulinism and how they might be related to ketotic hypoglycemia. Now, there is very little data in the literature about this, and so I'm going to summarize a few of the different papers. This first paper was in the Indian Journal of Pediatrics in 2018, and they described 4 cases of ketotic hypoglycemia that occurred after resolution of perinatal stress hyperinsulinism. Now, perinatal stress hyperinsulinism is a condition that occurs in newborn babies, typically who are born with intrauterine growth retardation, meaning they stopped growing while they're inside the mom's tummy, or that they underwent some form of perinatal distress around the newborn period. And this is a condition that occurs in about 1 in 1,200 babies, and about 1 in 6,000 babies need to be treated with diazoxide for this condition. So this is not a rare condition. And this paper basically described 4 children who had ketotic hypoglycemia after their hyperinsulinism was resolved. Now, Khalid Hussain, who used to work in Great Ormond Street in London, presented 2 cases of ketotic hypoglycemia while patients were on diazoxide. He and one of his colleagues then presented 6 children who had perinatal stress hyperinsulinism who were treated with diazoxide, but after completing the diazoxide, they developed ketotic hypoglycemia. And then there's a series of papers that look at different mutations in the genes that cause hyperinsulinism, such as the ABCC8 gene, that are associated with spontaneous remission of the hyperinsulinism, meaning that it goes away on its own, and then they develop diabetes later. So let me summarize all of the things that we just talked about. Firstly, children who are born with intrauterine growth retardation with acquired perinatal stress hyperinsulinism can develop ketotic hypoglycemia later in life. Children who have diazoxide sensitive hyperinsulinism develop ketotic hypoglycemia while they are on treatment with diazoxide. And certain forms of genetic types of hyperinsulinism, such as the dominant ABCC8 mutations, or children and adults with HNF1 or HNF4 alpha hyperinsulinism, stop having hyperinsulinism and convert later on to adult onset diabetes. So how is this important? Well, it's important to remember that everyone gets ketotic hypoglycemia if we fast them long enough. So therefore, the question is not, do children with hyperinsulinism develop ketotic hypoglycemia? The question is, do children with hyperinsulinism develop pathological ketotic hypoglycemia? So let me think about that a little more and talk to you about some possible explanations for the things we've just talked about. Number one is that 99% of the population gets ketotic hypoglycemia. However, very few people, and that's probably all of you here, have pathological ketotic hypoglycemia. Infants who are born with intrauterine growth retardation or who were born small for age are at increased risk of perinatal stress hyperinsulinism. But these children are also at increased risk of ketotic hypoglycemia later in life, especially if they remain small and thin. When children with hyperinsulinism are diazoxide responsive, it means that when they fast long enough on the medicine, the ketone levels will be greater than 2 millimolar when they develop hypoglycemia. So this is described as ketotic hypoglycemia by definition because you have high ketones with a low blood sugar, but this is not pathological ketotic hypoglycemia. Another explanation is that children with pathological ketotic hypoglycemia often have G buttons placed for the emergency treatment of hypoglycemia. However, we have to remember that 1% of children with G buttons get postprandial hyperinsulinism, which is a form of hypoketotic or low ketones with hypoglycemia. And this especially occurs if the child has a Nissen fundoplication done with the G button. And in fact, 25% of children who have Nissen fundoplications and G buttons performed will have a form of hyperinsulinism. And so you can see that if that was done to a child with ketotic hypoglycemia, they would then have two different conditions at the same time. Now, another possible explanation is that children with some forms of hyperinsulinism have spontaneous remission of their hyperinsulinism as they get older. And in order to prove that they have remission, they undergo a fasting study. And that fasting study goes so long until they develop low glucose with high ketones. And so the families are told that now you no longer have hyperinsulinism because you now have ketotic hypoglycemia, which proves you can't have hyperinsulinism. But what's important to remember is that that still could be normal. That's not necessarily pathological ketotic hypoglycemia. And then the last explanation is that children with pathological ketotic hypoglycemia may develop hyperinsulinism-like hypoglycemia if they're on a continuous dextrose infusion by a G button, or if they're on a continuous IV dextrose in the hospital and someone suddenly switches off the G button or it disconnects or the IV disconnects, and then you can drop your blood sugar really quickly and have a hyperinsulinism-like condition. So there are many possible explanations. So what do you do as the parent? Well, the first thing is that if your child did have perinatal stress hyperinsulinism or had hypoglycemia in the newborn period that went away on its own, either with treatment with diazoxide or without, and they're now off the medicine, and when they had their proof of cure fasting study, they developed high ketones and low blood sugar, then you need to ask your doctor several questions. The first question is this normal hypoglycemia with ketones that occurs when a baby or young child fasts for long enough, or is this pathological ketotic hypoglycemia? You need to know how long does it take to develop the ketones after an overnight fast. So for example, if this happens after 6 hours of fasting and your child is hypoglycemic by 9 hours, that's very abnormal, and that's pathological ketotic hypoglycemia. Whereas if it happens 14 to 18 hours after an overnight fast in a child who's less than 1 year of age, this is completely normal and not significant. You need to see, do you need to monitor the child's glucose or ketones? Do you need to do anything more than give them a bedtime snack? If your child has a form of pathological ketotic hypoglycemia and is treated with continuous feeds or overnight dextrose in a G button and they develop hypoglycemia after stopping the feeds, then in that situation we have to learn how to ramp down the feeds. In other words, let's say your baby is getting 50 mLs an hour of continuous feeds overnight, then instead of just stopping in the morning, sometimes you have to drop down to 30 mLs for 20 minutes, 15 mLs for 20 minutes, 5 mLs for 20 minutes, and then stop. And then that almost always causes the hypoglycemia to go away. And finally, it's always important to remember that there is always an explanation for the type of hypoglycemia that we are having. And the answer is that we just have to find it. So if you have a child who had hyperinsulinism as a younger child and is now having ketotic hypoglycemia, there is an explanation, and we just need to work with your doctors to figure out what the cause of this is, how severe is it, and what degree of treatment do we need to put in place to treat it. So I'll stop there, and I'm happy to take questions if anyone has questions.
5, 4, 3.
Welcome back to the second day at the annual conference of Ketotic Hypoglycemia International. For those of you who just tuned in, I just want to briefly share what the meaning of the fun QR code we have on the screen. This year we are fundraising for the first PhD going to investigate all kinds of aspects of idiopathic ketotic hypoglycemia. So if you would like to contribute into the research to ketotic hypoglycemia, please use the QR code and help us fund research. Now we are diving into a Q&A with our experts, and I am so happy to welcome both Paul, Pratik, and Joseph, and maybe Henrik will join, maybe. But for now, I would like to welcome Paul. You have just made a presentation about from hyperinsulinism to ketotic hypoglycemia, and I have some questions from the audience. And the first question. My child has ketotic hypoglycemia and reactive hypoglycemia. The KH is well managed with cornstarch, but the reactive hypoglycemia is out of control in kindergarten. I have heard about the medicine diazoxide being used in children with hyperinsulinism. Could this be relevant to us, or is the reactive hypoglycemia not caused by insulin?
That's a very good question. And actually, we already know the answer to that because first, the reactive hypoglycemia is generally caused by insulin. And so in that case, what you see is a low glucose and a low ketones occurring shortly after a fast. And in the past, people have tried treating this with diazoxide, and unfortunately, it doesn't work very well. In addition, there are a lot of side effects and complications of diazoxide. It is not a very pleasant drug to take. So that's another downside. We are learning a lot of things about this reactive form of hypoglycemia in the adult world, because adults who suffer from obesity and who have surgery to help them lose weight have a significant amount of this reactive or postprandial hypoglycemia. And so there are several drug companies trying to develop new therapies. But the key treatment at the moment is to adjust your diet, lower the amount of free carbohydrate that you're taking, eat a higher protein content in your diet, and in most cases, you can minimize the postprandial hypoglycemia.
Thank you, Paul. And just for the families who don't know what you're talking about when you're talking about postprandial hypoglycemia, that equals to reactive hypoglycemia. So that's just for the families. Joe?
Yeah, I think it's worthwhile to just add a little more detail to what Paul said. Obviously, I agree 100%. It is normal if we do a glucose tolerance test, or a person consumes what we call a high glycemic source of carbohydrates, in other words, glucose that is very rapidly absorbed. What that does is it stimulates a brisk insulin response, and it's the insulin that brings the blood glucose down back to baseline levels, and oftentimes there's an overshoot. The glucose drops below normal transiently and then corrects. That, for some people, that phenomenon is more pronounced than in others. But the point is, as Paul has already stated, if that is the case, then you have to avoid these high glycemic index forms of food and add protein, and I would say some fat as well, because what fat does is it slows down the rate at which the stomach empties, so that that spike of glucose that induces a brisk insulin response is somewhat muted. So I would say get rid of the high glycemic index carbohydrates, replace them to the extent possible with lower glycemic index carbohydrates, add protein and fat, and that usually takes care of the problem. And obviously, we're talking technical terms here. A good nutritionist would help advise a family on what would be appropriate food choices.
Thank you so much, Joe. And I know this is a very difficult topic for many families, as many children suffers from eating aversions after suffering from KH. But yes, thank you for advising also to talk to a nutritionist. We have a very active YouTube chat who are requesting Paul's attention to some questions. So I here have just a few questions to Paul. Paul, are there any incidences whereby ketotic hypoglycemia as a child then converts to a non-ketotic hypoglycemia as the disease progresses, or due to long-term overproduction of ketones?
Well, that's a very interesting question, and it's something I have seen. So obviously, if that were the case, one would want to have a good quality investigation to determine and see has something different happened. But remember, there are acquired causes of hypoglycemia that Mary Elizabeth talked about in adults. And so, for example, although very rare, insulin secreting tumors can occur. Hypopituitarism with injury to the brain following trauma can cause you to lose the ability to make cortisol and growth hormone. And sometimes conditions like that can cause hypoglycemia without large ketones. So I think if you have a change in the biochemistry, in other words, you go from ketotic hypoglycemia to non-ketotic, then non-ketotic hypoglycemia is almost always very serious. And so it does need a careful and thoughtful evaluation.
Thank you so much, Paul. And I will move forward with a question again, shouted out to Paul Thornton in the YouTube chat. Paul, our son has both GSD9A and mutation on the ABCC8 gene. Does he have an increased risk of diabetes?
It really depends on what that mutation is. Because in the general population, there's going to be a certain number of people who carry a mutation in the ABCC8 gene. So firstly, it depends if it's a variant of significance or non-significance or unknown significance. And then it also depends on whether it's a dominant mutation or not. But typically, we believe that just having one mutation in the ABCC8 gene does not increase your risk for having diabetes. Having said that, probably enough people have not been studied to be able to say that with, scientific precision. But if I were found to have a single mutation, I would not be worrying myself significantly that eventually I might develop diabetes. There are probably far more common reasons why one might develop diabetes than having one mutation, as long as that's not a dominant mutation, obviously.
Thank you so much, Paul. And now I will move the question to Joseph. My child has had hyperinsulinism, but is now presenting with ketones when low. This was discovered during a safety fast. The doctor said he's cured for his hyperinsulinism and has told us that his ketones will protect his brain. Is this true? He still has hypos into the 40s, and we can't check ketones at home.
I think this question was somewhat addressed by Paul's earlier presentation.
Yes.
That is that it's certain centers that have the resources when a child is being treated with diazoxide for congenital hyperinsulinism, or if one is testing the child to see if the condition has been so-called cured, the child would be fasted, and an endpoint is whether or not they can generate enough ketones to reach a level of at least 2 millimoles or 2.5 millimoles. Because if you do have hyperinsulinism that is persistent, even mild, that will prevent the body from generating ketones to that level. So my interpretation would be that in a young child fasted long enough, but who can make ketones and reach a level of over 2 millimoles, that child probably is cured and now has idiopathic ketotic hypoglycemia, or, as we have said earlier, normal healthy children, young children in particular, when fasted for long enough, their blood glucose will eventually drop below, 50 milligrams per deciliter or 3 millimoles. So I think that's the best I can say on that particular question. And I don't know if my colleagues who have a different opinion.
No, great. Thank you.
Well, good to agree, at least.
That's comfortable for us to feel like you all agree on this. So thank you so much for that. I have a question for Pratik. Is there a risk of unconsciousness with very high ketones above 4.5? My daughter's blood glucose was 3.3, so not too low, but her ketones raised up to 4.8, and she couldn't sit up, and she was struggling to stay awake.
So the raised ketones can also cause various signs and symptoms. Especially they feel very unwell and they feel sick. I mean, obviously the symptoms can vary, and at some point, when they have built up so much of ketones, they have been, or they have had dropped their blood glucose levels. So obviously at that time when you've checked the blood glucose, it's 3.3. But it is possible that the child had a lower blood glucose, and that's where the response was that they have raised the ketones. So it could be those symptoms of being drowsy and lethargic, could be possibly that the child had dropped the blood glucose, and then eventually the response was in ketones rising. So yeah, it could be those of the symptoms and signs, and 4.8 is quite high number, so they can feel quite unwell and sick as well.
Thank you so much, Pratik, for clarifying this. I am finalizing the last question, directing it to Paul. This is a mom trying to understand the terms. She says, my child has ketotic hypoglycemia and was just diagnosed with reactive hypoglycemia. Is the reactive hypoglycemia considered as hyperinsulinism, Or is it called congenital hyperinsulinism? Or is it just called hypoglycemia? What is the difference?
Yeah, so this is a difficult issue because a lot of people call things very differently. So, for example, we know the mechanism of blood sugars that fall after meal. And as Dr. Wolfsdorf reminded us earlier, approximately 25% of people who, for example, do an oral glucose tolerance test will have a blood sugar that swings high and then swings low down into the low 50s and then pops back up again. And in that case, we don't consider that a pathological condition. That's just an exaggerated response to a high blood sugar. And the trick there is eliminate free sugar and increase your protein and fat in your diet. And so it's very possible that, when children with ketotic hyperglycemia are put on a high added sugar diet to try and keep the ketones down, that a small proportion of them are going to have this normal reactive hypoglycemia. And so you just have to find the balance between that. Congenital hyperinsulinism is a name that's generally used for genetic conditions that cause abnormalities in insulin secretion and 60 to 70% of those babies present in the first 1 week of life, about another 25 to 30% in the first year of life, and it's very rare, like Bo, to present after 1 year of life, but it does happen, and we're now starting to understand the reasons why a little better. So basically they're all different conditions, some of them much more severe than others.
And with these words, Paul, I would like to thank you for your presentation and thank Joseph and Pratik for joining this Q&A. We are now moving forward to a well-deserved break. We will have a 10 minutes break and then we will be back to the final session of this conference talking about Munchausen by proxy in ketotic hypoglycemia. See you soon. Welcome back to the last session at the second day of the annual conference in Ketotic Hypoglycemia International. The session we are about to start now is a session I have wanted to make since the day my children received the diagnosis. The diagnostic odyssey of children with idiopathic ketotic hypoglycemia can be long and very, very challenging. What we are going to reveal here and unravel in this session is the untold stories and the narratives of the families, the struggles they are facing when they are searching answers for their children suffering from these unexplained symptoms. So, the first video we are going to see has been created based on the narratives of some of the families in KHI. I'm giving you a medley of narratives from the families.
In their words, multiple hospitalizations and mother requesting unnecessary testing. The doctors thought our baby was well and fine. I kept pushing to help our daughter and tried to get the doctors to help us. They thought that I wished that our daughter was ill. I believe this accusation was triggered by healthcare workers not taking me seriously when I repeatedly brought my child in for emergency care. I've had my child's doctors write in their notes that I was overly anxious. I spent tens of thousands of dollars of our money searching for physicians that would believe us. I was afraid of saying anything to the doctors. How could they ever think that about me? Further along, my husband and I changed our communication, e.g., he was the one saying everything and answering questions when we were at the hospital. We ended the corporation and found a private doctor which was more than willing to help us. We had social services involvement, resulting in a child protection plan for 9 months, as it was deemed undertaking a blood sugar finger prick put our child at risk of serious physical harm. Mom had to undertake a volunteer interview with the police due to the serious nature of MBP allegations. Family and friends and even healthcare workers finally realized I was not making it up when we were officially diagnosed. I had to take antidepressants for several years, quit my job. No one ever blamed my husband, only myself and my young child. I'm afraid that someone will think that about me again. It was awful sitting in front of a doctor and hear her assumption. I have trauma. I suffer every time my children need healthcare now. I have fears that if they are brought into a facility, I will be accused of not providing their needs or be accused of getting attention, and it makes me question trusting a healthcare provider again. I have since discovered the GP 13 years ago recorded on my medical history suspected MBP.
And we are now back after listening to some of the narratives of the families in KHI. Now we are diving further along into this subject, and I just want to say out a very heartfelt thank you to my scientific advisory board members who are brave enough to tackle this very sensible subject. And it's the first time I ever come across doctors who are willing to publicly speak about the diagnostic process of idiopathic ketotic hypoglycemia when we are talking about unraveling also the potential cause that the families might be starving these children. So now I am welcoming a presentation done in a collaboration with Dr. Henrik Christensen and Dr. Paul Thornton, followed by a patient story. Welcome.
Hello, my name is Henrik Christensen. I'm from Odense University Hospital, Hans Christian Andersen's Children's Hospital, Denmark. Now let's talk on Münchhausen by proxy or factitious illness in ketotic hypoglycemia. In my clinic and in the experience of the family organization, there's been many families who have been accused for over-dramatizing their children's disease and actually causing harm to the child by prompting too many investigations and unnecessary treatment. And this is a painful situation for everybody who is involved. You may call it Münchhausen by proxy or factitious ketotic hypoglycemia, which means that the child doesn't have the disease, but the symptoms are fabricated by another, typically the parent. Another name is perplexing presentations, which may lead to what is called fabricated or induced illness. Perplexing presentations is defined as situations where a child is reported to have symptoms or disabilities that impact significantly on their everyday functioning, yet thorough medical evaluation has not revealed an adequate and realistic medical explanation. But for now, let's just call it Münchhausen for ease. The problem is complex and can be looked upon from many sides. Firstly, the problem can arise because the physicians and authorities are totally unaware of the condition of pathological ketotic hypoglycemia. These authorities and physicians may think that ketotic hypoglycemia is only a mild and physiological and self-limiting disease of small infants, and that there's no reason to seek special help for that unless there's an acute illness. But if the child actually has pathological ketotic hypoglycemia and the professionals don't know about it, then the disease will be underdiagnosed and undertreated, and the parents will not be heard, and ultimately perhaps accused for over-dramatizing the problem and eventually suspected for Münchhausen. This is one potential side of the problem. Another side is that the parents, from the hypoglycemia expert point of view, sometimes overdo their care for the child and make life unnecessarily troublesome, even though the child actually has pathological ketotic hypoglycemia. This is not just a matter of Münchhausen, or you can say that the parents have their child's disease as a hobby. There are much deeper layers in this. And the deep layer is fear of hypoglycemia. Fear of hypoglycemia is a well-known problem in other conditions with hypoglycemia. It can be rational to have fear of hypoglycemia, but if you have excess fear, then it will lead to anxiety and reduced life quality in a way that is unnecessary and potentially harmful. This adverse or exaggerated fear of hypoglycemia is a well-known condition in type 1 and type 2 diabetes, and actually affects 1 out of 7 affected with these diseases. And I would guess that this is a very common problem that has not been addressed in ketotic hypoglycemia. If a parent has fear of hypoglycemia of the child, it will lead to anxiety and perhaps overcare and perhaps over-treatment, we could call it. And this should not be regarded as Munchausen, but simply fear of hypoglycemia. The solution is to collaborate with the parents, to give physiological support, and together obtain a clear picture of the child's conditions and needs. To get there, you need a solid diagnosis of pathological ketotic hypoglycemia and a solid overview about the extent of the problem, the frequency and the severity of the hypoglycemia. Once you together have documented how frequent and severe the hypoglycemia is, only then you can make an appropriate and precise management plan for the individual child. And this is often a long process. It's not easily done. And you have to collaborate, physicians and parents, to get there. Sometimes this can only be done in an expert center dealing with hypoglycemia. All physicians and social workers have an obligation to react on suspicion of Munchausen in the interest of the child, which we are employed to protect. But much can be achieved if the knowledge is spread about the existence of pathological ketotic hypoglycemia and the existence of excess fear of hypoglycemia as a psychological problem in families with hypoglycemia. In the best world, both undercare and overcare is avoided in children with ketotic hypoglycemia. The family organization may help other families with support if they're falsely accused for Munchausen by proxy. But also important, the family organization, together with the experts, can help by addressing fear of hypoglycemia as an important general problem in families with ketotic hypoglycemia. Parents with fear of hypoglycemia should not be blamed, but helped. Thank you.
Welcome back. I just want to highlight the last sentence Henrik made. Parents with fear of hypoglycemia should not be blamed, they should help. Meaning, we need to start talking about fear of hypoglycemia as a reality, because I can say as a mother, when my first child was diagnosed with IKH, I guess I was over monitoring. I was sure he was going to die every time I put him down to sleep. Today, both of my children have much more quality of life because I know much more about the condition, but we need to talk about it. And now we're moving forward with a patient story, an anonymous patient story of a mother who was accused of Munchausen by proxy.
As parents already, we headed into the pregnancy of our daughter optimistic that this pregnancy would go similar to our previous. We weren't naive enough to expect that there wouldn't be difficulties along the way. This is life after all. However, this pregnancy was a roller coaster, with one thing after another coming up, and was like nothing we had ever experienced before. The day came, and we were thrilled to finally get to meet this little girl we'd been dreaming of. Despite some of the issues with the maternity care in the hospital, our daughter was finally here, and we couldn't be happier. Those first few months that changed to years, we knew something was wrong, but we didn't know what. Our little girl cried more than normal, and she didn't gain weight like she should have. No matter what we did, everything she ate came straight back out. I was breastfeeding and pumping to make sure she got every precious calorie she needed to help her gain weight. We were working hard to ensure the very best start for our daughter. We sought out lactation support and medical advice, sharing our concerns about her lack of weight gain. Through our encounters with medical professionals, they came to the opinion that we weren't feeding our daughter and we were the reason all of these things were happening. During a hospital admission, nurses were assigned to feed our daughter, and they too all felt like her reflux wasn't under control and that her milk allergy was likely contributing to her difficulties. We slowly began to see improvements, but it became clear she needed medication for reflux. As she grew, her medication doses needed to grow with her, which didn't always happen. Her specialty formulas didn't agree with her body, and we were combining all of this with food, but our daughter's body just didn't agree. Hindsight is 20/20, and now that we know about ketotic hypoglycemia, we can look back and see how those signs were from hypoglycemia. It's hard to believe all of these symptoms existed in her younger years and were likely a massive contributing factor to her issues, but were missed by our doctors. As her parents, we felt guilty that we went along with these explanations because we believed that they were explained by other diagnoses. As she got older, we prepared for her to transition into daycare. We prepared ourselves for the usual childhood illnesses. Our other children had experienced them after all, but nothing compared to our experiences with our daughter. We fed her on demand, and our daughter was fed every 2 hours until she transitioned into daycare at 6 months old. This transition was where the weaning process started, and this, like all things with our daughter, eating was not a successful process with so many foods causing issues. The daycare called constantly. Our daughter was sick often. She'd have a fever, and in general, the staff said she just always seemed to look worse than the other kids when they weren't feeling well. Our other children at home had the usual childhood illnesses, but nothing compared to our daughter. Even our friends would comment on how often she was sick. There were also episodes of other concerning symptoms, particularly after lunch, snack, or early evening before we picked up our daughter. This concerned us, and we raised these issues with our daughter's medical team, but we were constantly dismissed. I'm sure you know the feeling. Your little one is sick, but the moment you finally get in to see the pediatrician, they suddenly seem fine. This was our daughter. Every time they saw her, she'd be fine for that brief 10-minute appointment. Around her first birthday, following a great day at daycare, our daughter became ill. She had a high-grade fever, was shaking, and as her parents, we knew something was wrong because she looked so sick. The doctor on call recommended we call 911 for an ambulance to be safe. Based on the description of our daughter and her age, he too was concerned. When the paramedics arrived and gained IV access, her blood sugar appeared normal. But we now know that that was a stress response due to receiving an IV from strangers while being held down, which can trigger a temporarily elevated blood sugar. The working assumption now is that her sugar had been lower and that we got a falsely high number. Our daughter was likely experiencing a severe hypoglycemic episode. She was clearly very sick with the virus, but she was alert and responsive during this event. Her blood sugar did crash again, and she was transported to the hospital. This would be the first time I was accused and assessed for Munchausen by proxy, as it is the protocol for a child being hypoglycemic with no specific cause. During this hospital admission, the team was finally able to see the feeding difficulties we were having and no longer question their legitimacy. However, our daughter continued to have repeated hypoglycemia in the mornings and every time she spiked a temperature from the viruses that she had caught. Despite all of this, we were told hypoglycemia with illness doesn't happen and that we were just not feeding our daughter enough. We were told not to worry, that the hypoglycemia wouldn't happen again. And since we are all taught that doctors know best, and after the terrifying Munchausen by proxy allegations came to nothing but a phone call from a child protective service worker, we sighed a sigh of relief and worked on getting our daughter over the infections that had landed her in the hospital. As we left the hospital that day, in the back of our minds, we wondered if they were right. Was she safe, or would her sugar crash again? As we tried to transition back to life, we were assured that all was well, and that we just needed to keep pushing food. We tried hard to get life back to normal, despite receiving phone call after phone call from our daughter's providers about poor feedings, distress, or illness. At one point, we added up the calls and in a single week had received over 20 calls from providers. Despite this, we managed it with only a handful more trips to the hospital. Our daughter would act the same way she did on that first ER visit with her first officially recorded hypoglycemic episode. But despite our concerns, the doctors wouldn't check her blood sugar and dismissed the concerns we had. It was because of these concerns and requests to monitor blood sugar that I started to be accused once more of having Munchausen by proxy. Records indicate that the providers noted, quote, "She is anxious, concerned, and something we've explained as not concerning and potentially making up or exaggerating what she sees," end quote. When in fact, I was terrified because my daughter was not thriving. Everything was an uphill battle, and my maternal instincts told me something was very wrong. I remember it almost as if it were happening now, that very first admission for hypoglycemia. I remember the fear that my daughter was sick and her sugar was dropping before my eyes. I remember the fear of watching while no one could get an IV placed for the infusion she desperately needed. Her little eyes slowly drifting off to sleep despite the chaos around her, and her skin becoming paler and paler. As a parent living with these memories, I don't think it's unreasonable to be worried, anxious, or scared. I thought that sharing these concerns with doctors would help them see why I was so scared. I never imagined they'd think that I was harming my own child. This is the trauma of ketotic hypoglycemia. The lack of knowledge on ketotic hypoglycemia fails our children repeatedly. And sometimes that lack of knowledge leads to allegations of abuse. It makes no logical sense when a child is at the center of it all. It makes no logical sense when our hospital treats other patients with ketotic hypoglycemia. One would assume that everyone on staff would recognize the signs, yet we just kept being told to feed her more. And I wish that had been the end, but she eventually got sick again, which caused very high fevers, resulting in blood sugar drops into the low 18 to 20 range, but ranging between 18 and 36 is dangerous. And we tried so hard to manage these sugars at home, but when we did everything we could think of and nothing worked, we would eventually take her to the hospital. Sometimes they'd keep her for observation and tell us we could manage these at home if we just do as we were told with the medications they'd prescribed. There were never follow-ups arranged, never an emergency plan in writing to tell us what to look for or when to be worried. It was just another black mark against our name. We were doing our best as her parents. We asked to be connected with a team who'd carried out some CGM monitoring around our daughter's first episode that showed regular morning lows and was the reason we had been given the advice to feed her more. We explained what she'd been experiencing, and a fasting study was arranged. We confirmed a diagnosis of ketotic hypoglycemia. I'll never forget the frustration and the hint of anger in my soul at those words, because this was the very same doctor who told us months beforehand that there was no such thing as an illness, infection, or a condition that would cause these lows. This hospital treated a number of children with ketotic hypoglycemia, and this doctor, who was so dismissive, managed many of them. It was a confusing time. They finally gave us plans on how to manage her, but the advice was done in such a disjointed way that we were never walked through the diagnosis and when to worry or not. This just continued to lead to unresolved concerns and worries that we had as her parents. We came to understand through trial and error of many more episodes of hypoglycemia to monitor our daughter and check her sugar every morning and evening. We learned to check her anytime she appeared unwell. Though this trial and error on a journey of which we still felt so alone, we found our daughter's regular morning numbers to be between 30 and 50. We caught lows after her afternoon nap, which coincided with when daycare would call concerned. We found through all of this that ketotic hypoglycemia lives in this medical gray area. Even though we were following all of the provider's advice, how was our daughter still experiencing random lows when you least expected it? We wondered, had the hospital missed something? Did we not understand something properly? We still felt like we needed more guidance, but these questions and concerns only led to another allegation of Munchausen by proxy. Then this led to repeated admissions to the hospital with them running test after test. And we thought that they were trying to help our daughter. But as it turned out, they were trying to find something, anything to prove we were doing this to our child and support their allegations. Eventually, the conclusion was made that we didn't meet the threshold of risk, and the team had uncovered no evidence to disprove the diagnosis they'd already given our daughter. So instead, we were told we were abusing our daughter by checking her blood sugar, because children with hypoglycemia, in their professional opinion, do not need to be checked, because this is a normal childhood issue which she would eventually outgrow. While we didn't agree with any of this, we tried to carry on and trust that doctors know best. For a child who has looked and can look fine with a very low blood sugar, it was hard to be sure she was really okay. We would still worry, but we had to try to carry on and continue to do what we knew worked. While we didn't meet the threshold for Munchausen by proxy, there were moments when the police considered talking to me about the doctor's concerns that I was harming my child due to the serious nature of Munchausen by proxy. They came to change their minds, but the hell and trauma of being told that you will have to talk to police officers because they believe you had potentially abused your daughter was gut-wrenching. To have Child Protective Services calling you when all you had done as parents was advocate and seek out support for your daughter, it's hard to express in words. It's a pain that is so hard to put into words. It's helplessness and frustration, and you start questioning yourself constantly that maybe you're going crazy. It's like dealing with gaslighting from your medical team and people who have the power to take your child away. When these allegations were dropped again with no action, we sighed a sigh of relief and tried to focus again on moving homes. During the pandemic, we had a very stable child whom we spent a lot of time working on food and eating habits without the chaos of daycare. This meant we could make strides in improving her relationship with foods and better understand her relationship with food in general. In the middle of this downtime, when the world was on lockdown, and we were so grateful to get to spend more time together as a family than we ever had before, she had another episode. Her sugar dropped to the 40s and she was symptomatic but awake, but this time she wasn't sick. We weren't able to fully treat the ketotic hypoglycemia episode at home with the medications we had from the hospital, and our daughter returned to herself. At this point, we were split on whether to raise our concerns again. Why was this safe and okay that even when we do everything they advise, her sugar still dropped? Why was everyone carrying on as if our daughter was okay and this was normal? It was a dilemma for us, but ultimately our daughter and her health came first. We were scared that these lows could be doing to her, so we raised this with the doctors again. I'm sure at this point you can guess what came next. Another accusation of abuse. Another accusation that was again not investigated by Child Protective Services. Our hospital had proof of these lows. They had fasting tests and other tests, and they knew they were not getting anywhere with all of their referrals. But they pushed these allegations, and when it didn't work, then they tried to remove our daughter's diagnosis. They said they'd never seen any of the lows in the hospital, that our daughter had never suffered from reflux or food issues, and they stated that every symptom our daughter had only happened in front of me. Then Child Protective Services had to act. Then, as her parents, those allegations of Munchausen by proxy fit. Despite having mountains of evidence, Child Protective Services believed that the doctors were right for nearly 2 months and wouldn't look at our reports from her daycare family or friends. They refused to review the video evidence, the letters on provider letterhead, or the stack of medical records in our possession. The hospital had convinced everyone of their narrative. We went through hell with the last referral. I was treated as if I was a child abuser. So many professionals were inserted into our personal lives, and that too became overwhelming. But then, to have it all just go away with no apology for the hell that we were put through, having to prove our daughter had ketotic hypoglycemia all over again was more than anyone could bear. I had to volunteer to allow the police to interview me, which was one of the scariest things I've ever had to do. I am so thankful that they dismissed the allegations within 24 hours of us presenting all of the information we had gathered over our daughter's life. Asking for things in writing saved us and our daughter. And we were so lucky we got to keep our daughter and other children at home. What was truly horrific was the level that the doctors who were involved stooped to. It's something that we and our close family and friends just can't understand. This entire incident has caused our friends and family to trust their medical team just a little bit less. We kept fighting because we knew we had done nothing wrong, and because her future depended on them acknowledging that our daughter did have a diagnosis of ketotic hypoglycemia. We have been left living with this trauma, trying to act as if life is okay. We are terrified to check our daughter's blood sugar when she needs to be checked. But our ultimate goal has been and always will be the safety and health of our daughter, including verifying her blood sugar is okay when in question. We live every day with the anxiety of checking sugar and knowing what that has caused in the past. We don't talk to providers about any of our children without recording the meetings. We ensure that we all have these records and details we spoke about because we can never trust that we won't be in that same position again. We know these types of allegations stay in medical records as if they are fact, even when they are disproved and you are proven innocent. In our situation, we believe they knew there were failings on their part as doctors and the hospital. Had they appropriately cared for our daughter and educated us, we as a family could have been empowered in caring for our daughter on her journey through life with ketotic hypoglycemia. Instead, we live in fear of every healthcare encounter, every hospital admission, which is horrendously exhausting. And when she's in the hospital, we know we need to be there with her, but the stigma attached to being overly anxious parents who have irrational concerns will follow us forever. Our daughter's healthcare plan to manage her ketotic hypoglycemia isn't always followed because each doctor will make a judgment on how they treat it. Whether or not they actually follow the medical protocols set out by her regular doctors is common with other rare diseases as well. As parents, we haven't slept properly for years. We know our daughter drops overnight. We know her sugars drop in the day too. There is never a day we can let our guard down. We can never drop the ball on feeding or management because our health team doesn't take it as seriously as we do. And they argue that ketotic hypoglycemia is a condition that only affects a child when they're sick, and therefore it needs no monitoring. But our child, our daughter has symptoms even when she isn't ill. The doctors even go so far to say we shouldn't be concerned about ketones. Now, when we came home after she had been in the hospital, every time the phone rings or the doorbell goes off, we dread that the doctor we dealt with has decided that they think we are making it up again. We aren't able to change providers, and we aren't brave enough to keep challenging the providers to figure out an answer. Ketotic Hypoglycemia International has saved our family, and our story is not dissimilar to many in our group. That is why we are sharing our story today here at this conference, with the hope that other families won't have to suffer what we do or live in fear the way we do just for treating our daughter's rare medical condition.
Welcome back to what will be the last Q&A of this conference. We just listened to an anonymous story of a family where they were accused of Munchausen by proxy. Before moving on to the Q&A, I would just like to highlight that all of the video clips you have just witnessed is stock video. This is an anonymous story, so you have not seen any of the families involved in this case. Before moving on, I would like to simply just welcome again our amazing Scientific Advisory Board members, Dr. Paul Thornton, Dr. Joseph Wolfstorff, Dr. Pratik Shah, and the head of the Scientific Advisory Board, Dr. Henrik Thybo Christensen. And now we also have Dr. Mary Elizabeth Paddy. Thank you all for joining in for this important Q&A. I would like to pass the word to Dr. Joseph Wolfstorff, who would like to make a statement.
Thank you, Danielle. I just first want to begin by saying that I tremendously admire the brave parents who have shared their profoundly disturbing stories. I can only say that I find them tragic. As a physician, I am ashamed that they've had to experience these sort of nightmares and continue to do so. At the end of the day, I can only say I'm accountable for my own behavior, and as a physician and teacher at a major medical center, I do my best to pass on my own knowledge and experience. But the specific comment that I wanted to make, if I could, to take advantage of this moment, I have come to the conclusion, it's been said, Paul Thornton, my esteemed colleague and friend, said it, I think, but I want to reiterate. Hypoglycemia is a biochemical disorder that has non-specific symptoms and signs, and oftentimes it is not diagnosed in a timely fashion. I spend a lot of my time taking care of children with diabetes mellitus, also a biochemical disorder, which is characterized by the opposite problem, namely abnormally high blood glucose. And 30 to 50%, and in some places even higher numbers of children with newly diagnosed diabetes present in a life-threatening condition called diabetic ketoacidosis. Oftentimes, these children have been to see a physician once, twice, 3 times before they are finally diagnosed. And occasionally, thankfully not too often, these children actually die from ketoacidosis. So the point that I'm making is that I firmly believe that in the year 2022, the measurement of blood glucose should be a vital sign, just the same as when a child shows up in an emergency department or in a doctor's office, the temperature is taken, we measure blood pressure, heart rate, respiratory rate, oxygen saturation. I believe we should prick the finger and measure a blood glucose. And I hope that that message is adopted, and Ketotic Hypoglycemia International perhaps can beat that drum as well. But I firmly believe that glucose measurement in a sick child should be a vital sign. Thank you for the opportunity to express my views, Danielle, and you should now go on with the Q&A.
Joseph, it was a pleasure to give you the word. It is always a pleasure to give you the word. Thank you so much for stating this, and I hope that the Scientific Advisory Board members agree, because I think it sounds reasonable, but I'm also a mom. But you as doctors, maybe someone wants to add on it? Pratik. Oh, Pratik, you need to unmute yourself. Thank
Oh,
you.
okay, yeah, thank you. Yeah, no, I fully agree what Joseph said. I just wanted to mention one thing. I think we'll all learn in our medical school, and when we do this research course, it's called ABCDEFG, which is called airway, breathing, circulation. And the last you end up is don't ever forget glucose. So it's ABCDEFG. And that's what we would always say to, to medical doctors and, students who actually does resuscitation courses. So, and that's just, I wanted to add that. Thanks.
Thank you so much, Pratik. And if no one else has something they want to add on, I would like to dive into the first questions from the audience. This is from, Mary?
from the adult endocrinology perspective. Unfortunately, such a heartbreaking story has echoes even in adult care. Many patients with hypoglycemia are not diagnosed for years and are thought to be suffering from anxiety or other disorders. And there's very little recognition that hypoglycemia does exist, even though it's uncommon. And so I think that I've seen many patients, adults, who are really just grateful that hypoglycemia has been recognized and diagnosed. And it's unfortunate that the medical community doesn't always recognize hypoglycemia. Perhaps, as Dr. Wolfsdorf mentioned, because the symptoms are nonspecific. And so unless you're really thinking about hypoglycemia, you can attribute it to lots of other disorders. And hopefully with increased awareness, that will slowly change. So, thank you.
Thank you so much, Mary Elizabeth. And I would actually like to add on to that because we have a question from the audience asking, can hypoglycemia be misdiagnosed as mental illness? I guess you almost answered that. Henrik? Henrik, you need to unmute. Now you're here. Thanks.
Yes, sure, it can be misdiagnosed as mental illness because some of the symptoms, anxiety, sweating, uneasiness, may mimic, and the unawareness of the physicians about the existence of hypoglycemia is contributing to this misdiagnosis.
Thank you.
I would like to add on the ABCDEFG. Please also check the ketones. Take a K as well if you have a low blood sugar.
Thank you so much, Henrik, for stating this. I will dive further into a question, and I will direct this to Paul. After Munchausen by proxy has been ruled out, how can we as parents safely advocate for our babies? The MBP process is continued trauma and harmful for our babies' care as we get afraid to advocate for them.
I think a very, very important question. And before I say anything more, I also want to reiterate what Joe said, which is that as a physician who cares for children with hypoglycemia, I find it embarrassing that so many other physicians just have such a high degree of lack of knowledge. And, you know, as Joe is very aware, we've worked on guidelines to try and disseminate the word that hypoglycemia is a serious problem. And for some other conditions, the hyperinsulinism families, we've developed guidelines on the management of that condition. So I think it'll be very important for us to continue the work that we started a couple of years ago and develop more guidelines. Now, to specifically answer your question, I think the best thing to do is to have a clear conversation with your physician and say, would you please put into the discharge summary why you thought this was Munchausen's by proxy, what evaluation you did to prove it was not Munchausen's by proxy, what is the current diagnosis, and what is the future management plan, both, as Dr. Dirk says, in the home to prevent hospital admission, and when that fails, in the emergency room to prevent hospital admission from the emergency room. And I think if you can get all that documented, get a copy of that discharge summary, and bring it with you to your next visit to another physician, another emergency room when you're on vacation, and show it to them, that'll help a lot. But I think that would be my best advice. You know, let's be open about the concern, let's document that we proved it was not, and let's have a diagnosis and emergency plan that you can follow that will hopefully keep you out of the hospital. And if not, the physicians will know that, you know, someone has given this careful consideration and done the proper evaluation and has shown that this child has pathological ketotic hypoglycemia.
Thank you so much, Paul, for this. And I will dive into just another question, almost down this alley, but yet not. And I will direct this question to Pratik. Hi, I am a mom from the United States. I have been accused of starving my daughter. I am a single parent. I have looked into the signs and symptoms of Munchausen by proxy, and I see why I fit this description. First, I am a single mother, and I am the only caregiver of my child. I have read all scientific papers I could find on ketotic hypoglycemia. However, I am not starving my child. He is having severe incidents of ketotic hypoglycemia, but he did not drop in the 12 hours fasting they did at the hospital. I am terrified of losing my child. I am afraid to seek other medical professionals, as I have heard stories of mothers being accused of doctor shopping. What can I do to advocate for my son without losing him in the process due to MBP accusations? Pratik, do you have any idea on this?
Can you see me now?
Yeah, I can definitely see you.
Yeah, I think it's a very difficult question, and obviously it's a difficult situation as well to know. I think more importantly is that needs sort of more information about what the investigations have been done, and if it has been seen by a specialist, as well as making sure that they have undertaken all the investigations which was necessary. And more importantly, I think, as we've discussed in the earlier as well, that I think if you have any concerns, I think it's best to discuss with your GP or your physician, and asking about if there is anything else, or we say discussing with someone, with a specialist, and see if there needs to be anything else. So it is very difficult. I completely understand, and what we are here is to just make sure that we create more awareness amongst the healthcare professionals, and discussing with families and family organizations like this, and asking for help. I don't know if any of my colleagues would like to add anything as well.
Henrik?
Yeah, I should perhaps like to add that more monitoring should be performed, as a single fasting test may not tell the whole story. It may be rather reactive hypoglycemia, or maybe a repeat fasting test would show something different. Home monitoring is a good tool for adding on about the frequency and severity of the hypoglycemia. If the doctors still don't trust home monitoring, then you would need more hospitalization, and not only perhaps fasting, but also postprandial blood glucose values.
Thank you so much, Henrik. From a parent perspective, I just want to say we're talking a lot about seeking out specialists. I was once in a situation where I had to tell the doctor that I would like to see a specialist. The problem was that this doctor believed he was the best specialist. I had to tell him I found someone who were more specialized than him. And that's very difficult for a parent. We are dancing around with egos. And what can the consequences be for these families if they are calling out this doctor to not be the specialist? Just saying, it can be very, very difficult to find specialists if this doctor you're seeing is perceiving himself or herself as a specialist. How can we please get a list of doctors who are actually specialists, so we can also give them to the healthcare professionals and show them you are not on this list? Joe, you're laughing, but I'm deeply serious.
Yes, Yeah, I mean, I think we've already put it on the homework list, Danielle,
Yeah.
that we need to
Yes.
get a list of all of the specialists in each country and, work together. There are several other physicians in the United States who are very interested in hypoglycemia who are not here. And so we
Yeah.
know who they are. And I'm
Correct.
sure it's the same in the UK and throughout Europe. Not everyone who's interested in hypoglycemia is here, and there are others.
Yeah.
But it is very difficult. Doctors have huge egos. They think they can't be wrong. And I think what we just have to learn is how to ask the right questions. And, it's very important to ask the physician, if he's suspecting you of Munchausen's, have an open discussion and say, okay, why do you suspect that this is Munchausen's? And then they'll tell you what they think. And then you say, well, what can we do to prove that those things are not true? And, if they say, well, we have to bring you in to do a fasting study, or we have to bring your baby in and to feed them for 2 days to see can we suppress the ketones, then you say, okay, do it, because I believe there's something wrong with my child. And when you bring them in and they demonstrate that something is wrong, then you now have the ammunition to say, okay, so now you understand where I'm coming from. So I think that's very important. And I think it's important that, that we learn to have that very difficult conversation, because I can tell you, if someone accused me of Munchausen's, I would be furious. And I would probably not be able to be calm enough to have a discussion. And I think we know that families in this organization, have a higher risk of this being leveled at them, because most don't understand that there are severe pathological forms of ketotic hypoglycemia. And so we should be prepared. We should have a set of questions. And I think that's another thing the organization can do, is they could have, a guide to the family. If you're accused of Munchausen's by proxy, what do we need to do to get that diagnosis cleared? And I think the Scientific Advisory Board can help you with that as well.
Thank you so much, Paul. And I think that relies back to let's get this standard, gold standard of a fasting test, what to do, how to do this, and make sure that everything is ruled out. Because we're seeing a lot of these families being admitted, and then they have a very short fasting test, and when the kid do not drop within 12 hours, then the accusations of MBP is suddenly raised. But I will just move forward with a question. You have already answered it, but I just want to show you some of the consequences of MBP accusations. This is a mom stating, I am under investigations for MBP due to the genetics coming back negative. This has caused me to now have anxiety to call 911 even when I know I should. How do I keep my child safe without losing her due to MBP? You already answered this, Paul, and I just want to share it because I think it's really powerful that this fear can suddenly cause the families to not seek out medical help when they actually need to.
Sorry, Daniel. Yeah.
Joe?
Sorry, yeah. I can tell you I've recently seen 2 children with severe ketotic hypoglycemia who we've worked up extensively, hospital admission, fasting studies, comprehensive genetic panels that were negative. The genetics did not give us the answer. All it tells us is that we haven't been able to make a precise diagnosis. It doesn't negate the fact that this child has pathological ketotic hypoglycemia, and that has to be managed. So a negative genetic test doesn't solve the problem. The diagnosis doesn't go away.
Thank you, Joe. And Paul?
Yes, that's exactly what I was going to say.
I'm so glad you're all aligned. Great. Thank you. And this, I guess, is inquiry for both the organization and the Scientific Advisory Board. Can KHI and the Scientific Advisory Board make a scientific study or a scientific statement about MBP and pathological KH It seems like doctors only believe what they read in medical papers. Yes, Henrik?
Yes, I think this session here clearly shows that there is a need of making a paper about this issue, because there's so much lack of knowledge, and this frequently leads to accusations of MVP. And for this specific disease, of pathological KH, it would be appropriate to make such paper, I think.
Anyone else, Joe?
Yeah, I'd like to just add, we've been talking here about the lack of humility on the part of physicians who think that they know everything and so on. We all know that that's nonsense, that we keep learning, that the things we think we understand turn out to be wrong, and that new research sheds more light on problems. I was just thinking about when in my early days as a pediatric endocrinologist, we used to talk about a disorder called nocidioblastosis. We had no understanding at all about the numerous genetic causes of congenital hyperinsulinism that have emerged over the last several years. So how does this relate to ketotic hypoglycemia? The classic notion is that ketotic hypoglycemia is a variation of normal. The child will outgrow it by the time they're 7 or 8 or 9 years old. They only have this problem when they've been unusually active or they're sick and not eating properly and so on. And we now know that that's nonsense, that there is a mild form of ketotic hypoglycemia that may be a variation of normal, but there are also very well characterized pathologic causes of ketotic hypoglycemia. Henrik yesterday spoke about GSD9, for example. And I'm sure that in time we will learn that there are others that we haven't yet been able to pinpoint precisely what is the etiology. And I think that that's the message that has to be publicized in the textbooks, in the pediatric journals, and so on. And hopefully over a period of years, we'll shift the understanding a little bit. That's my thought about this particular problem.
Thank you so much, Joe. I just have one question more from a mom before moving forwards to all of the other questions we also have. I have been accused of Munchausen by proxy, and the charges has been dropped. However, the doctors still don't think I should monitor his blood sugar, despite the fact that he had dropped down to 1.2 before exhibiting symptoms. The school now feels unsure about having him in their care, and they want to monitor his blood glucose. I would like to give him a Dexcom, but I am so afraid to be accused of MBP again, as I guess they will consider it as over-monitoring. What can I do? Paul?
Well, you picked me for a really difficult one, didn't you?
Yeah, I always do.
This is very tricky. I mean, I think what's important is to understand and determine why the doctors think that you don't need to do the monitoring, and then if it's based on inaccurate data, then we have to find someone to help you get the accurate data, because all of the doctors know that fingerstick blood sugars, because we say it in the guidelines, should not be used to make a diagnosis of hypoglycemia. We say in the guidelines that the Dexcom should not be used to make a diagnosis of hypoglycemia. So everyone knows that they're inaccurate. And so really, I think what we need to do is to figure out in your individual case, when your child is having low blood sugars, are they truly low, or are there problems with the meter? So there are lots of things in each individual case that you need to be concerned of. But I agree with you, after hearing our last speaker, who was so brave to speak and talk to us, that having been Munchausen's ruled out 3 or 4 times, she goes back to the hospital and they accuse her again. So it's very difficult, a difficult situation. And what I think I would want to know is, just how at risk is your child? Because, for example, if someone is just a little reactive postprandial hypoglycemia, that's probably not going to cause harm. And therefore you would put in place a different plan. So this comes down to such an individualized approach. And if Dr. Wolfsdorf tells you, I don't think you need to be monitoring your blood sugar in school, then I think we can rely on that. If Joe Bloggs, a doctor who does not have much experience in this, says it, I don't know that I can rely on that so much. So it comes down to all of those questions.
Yeah, and then it's coming down to the calling out the doctors as non-experts. So that's a very tricky one. But yes, thank you also for stating the brave mom who has just shared the story. She's one of the bravest patient advocates I have ever met, and I know making this story took a lot of strength and courage to do it. But she did it, and I'm so proud to be a part of that process. Now we are moving forward into some different questions not related to MBP, but for the audience, if you have more questions related to MBP, just keep it coming in the YouTube chat. This is related to cycling vomiting syndrome. A mom asks, the doctors are unsure if my child has ketotic hypoglycemia or cycling vomiting syndrome. Can someone explain me the difference? She's severely ketotic. She has incidents with documented hypoglycemia below 50, and she has issues with vomitings in the morning. Henrik.
Well, it seems like this cyclic vomiting truly is caused by ketotic hypoglycemia. There may be situations where another substance that we do not measure is toxic for the brain and provokes vomiting. As far as we don't know what all types of ketotic hypoglycemia comes from, there may be other toxic substances that we don't measure, and that may explain why in some cases there will be vomiting without either ketosis or hypoglycemia. Moving back to cyclic vomiting, this is an unexplained disease. It's our experience that a lot of those are not truly cycling with a precise day-to-day variation or week-to-week or month-to-month variation, but rather morning vomiting that comes from time to time and actually often can be caused by KH.
Thank you so much, Henrik. Does anyone else have something they would like to add into the cycling vomiting syndrome? Paul?
Yes, I would like to say that over the last 2 days, as I've listened to all the families ask questions on YouTube, I am fascinated by how many of them have GI disorders. And, one of the problems is that if you have a bad motility disorder, that's causing vomiting, then you're not going to keep down your food. You're going to become ketotic. And then as your ketones get higher, that's going to trigger more vomiting. So I think, important members of the multidisciplinary team to children who have severe pathological ketotic hypoglycemia is GI doctors who understand the different issues. And I'm just struck with the number of people who have associated GI issues. And I wonder if you have bad GI issues and they're causing failure to thrive, you're going to have ketosis. So which comes first? And that's very important, I think, for people to take a clear history, try and understand, what happened and the order of events. And, we've heard very nicely from one of our colleagues that having to force feed children to prevent hypoglycemia develops, feeding problems. But, feeding problems also happen in children who don't have hypoglycemia, but then they are unable to eat properly and get ketones. So I think it's very important for us always to look at the whole patient and not just look at the ketotic hypoglycemia on its own, but to think about, are there underlying factors that could be causing it? So for example, with the cyclical vomiting, I think it would be very important that at the very first onset of symptoms, a blood ketone level is measured, or you determine if your child is able to fast overnight without getting the ketones elevated, because it may be that someday they're a little elevated and you eat breakfast and they go down and you don't start vomiting. So there are so many different approaches that can be taken in each individual child. And this condition reminds me very much that each individual child has to be evaluated and treated individually with a plan made for that person. And this is not a condition of one size fits all.
Thank you so much, Paul. That's why I always give you the hardest questions, because you always have a bright answer. Thank you so much. I am now moving forward with, Mary Elizabeth, please.
I just wanted to mention that, I do not take care of children. However, what I find interesting is that many of the adults who have unexplained hypoglycemia that's not insulin driven actually have other coexisting disorders, such as motility disorders and migraines. And these often coexist, and we don't understand the molecular or genetic basis of these conditions, but it's a very common set of diagnoses that coexist. And so I hope that over time we have a greater understanding of these relationships between the gut, the brain, and the control of glucose metabolism. And so I'm hoping that that's an area that we will understand better as time goes on.
Thank you so much, Mary Elizabeth. And Joe?
Yeah, Mary Elizabeth's comment prompts me to just add one additional thought. Let me just state from the beginning, we don't fully understand the condition of cyclic vomiting, and as Henrik has already said, we don't know which is the chicken and which is the egg, because if you're vomiting continuously for some reason, whatever it is, you're going to develop ketosis and potentially hypoglycemia. So, but it has been suggested, but I don't know how good the evidence is, that cyclic vomiting may be a form of so-called abdominal epilepsy, and so some form of seizure disorder that triggers the vomiting. And in some instances, a neurologist may be helpful in trying to manage the patient, in addition to, as was suggested, a proper gastrointestinal evaluation. But I think we still don't fully understand this condition.
Thank you so much, Joe and Henrik and Paul and Mary Elizabeth. It sounds like the cyclic vomiting syndrome is just as unexplained as IKH. I will move forward to another one. I think this is liver related, but I'm not a doctor, so you guys and lady will know. Is there an association between IKH and yellowing skin? She seemed fine and her eyes were white, so I didn't bring her in. And this mom sent me pictures, and I can tell you this is yellowing of skin. Anyone? Joe?
Did she say that only the skin was yellow, or was the white of the eye also yellow?
It was only the skin.
Well, I think of sort of yellowing of the skin as suggesting too much carotene, which is a condition called carotenemia. I can't think of an association other than to say if the child loves carrots and squash and yellow vegetables, that could be a cause. I can't think of another link at all.
Thank you, Joe. And Henrik, do you have something to add?
I think it may be serious that you get jaundice or yellow skin. I don't know the age of the child, but even though it's not a newborn but an elder child, should be evaluated for liver disease or gall disease.
Thank you so much. Anyone else? No? Then I have a question very dear to my heart, as I have experienced something like this. A mom asks, my 1.5-year-old still breastfeeds every hour. Her big sister has pathological IKH. Is there a connection between this nursing pattern and KH? Henrik, say something.
Yeah. Yes, we could call this hypernursing, but that's hard to define because in different cultures there are different normalities for nursing or breastfeeding. But having an elder sibling with ketotic hypoglycemia, it should be looked upon whether this younger child also has this condition, because the mother could instinctively try to protect the child from the symptoms the mother feels the child have from ketotic hypoglycemia. So she's already perhaps treating her child with frequent meals to avoid the child's discomfort, and surely there should be efforts to diagnose whether this child has ketotic hypoglycemia.
Thank you so much, Henrik. Pratik? You need to unmute. I love when you speak and I can't hear it.
Yeah. Sorry, yeah. I just wanted to share an experience that we had an infant who obviously was waking up hungry, and every 1 hour, 2 hours, and the child was about 12, 13 months of age, and then subsequently diagnosed to have hypos. So again, just something that whether the symptoms or the hunger symptoms or the child waking up, is it related to low blood glucose levels?
Thank you so much, Pratik. I have a question about teeth. Is there a connection between bad teeth and ketotic hypoglycemia? And I know this is children with ketotic hypoglycemia who has issues with their teeth. Anyone have heard anything? I'm not directing this at anyone because I'm not sure there is any evidence on this. Silence means no? No one have heard anything?
Okay, I'll say something for you, Danielle.
Thank you.
So there is a little bit of information, but I don't think this is the cause of the problem. But certainly when we have to feed our children frequently, when we have to give them carbohydrates at night, they're at much higher risk of dental caries just from glucose in their mouth. And the frequency of feeding may not lead to an equal frequency of dental hygiene or brushing your teeth. So there is a risk in children on high carbohydrate diets of having worsening of the dentition. But in the chat on YouTube, what I saw a lot of discussion was that adult teeth are coming in with abnormal dentine and abnormal teeth when the baby teeth were going out without, serious cavities or infections in the gum. And could there be an effect of high ketones chronically on the formation of new teeth? I think was an issue that we heard a lot of in the chat. And I think the answer is we don't know. And this is something that a registry would help us with, because maybe that's a question we would ask in the registry and try and see, is it associated with the kids with the worst degree of ketosis or what the association is. So this is another argument why we need a patient entered data registry so that we can look at all of these little issues that some families are noticing on their own, but maybe I never saw in my clinic. And maybe, Dr. Wolfsdorf has 5 kids with it in his clinic and he notices it, but we haven't put it all together. So I think a patient registry would be very useful to start looking at these little things to see how common they are, what the associations are, and start driving research thoughts to guide us to look into those sort of questions.
Thank you so much, Paul. And I guess this will also be the case for the next question, where they are asking about a correlation or an association between low vitamin D and IKH. We're seeing a lot of families talking about low vitamin D in their child with IKH. Has anyone seen that? Yeah, Henrik.
Yeah, low vitamin D is a frequent condition, especially in winter time and in northern latitudes, and to my opinion, it has nothing to do with IKH, but it's just a coincidence.
Thank you so much, Henrik. I have one more question, and this is about weight charts. My daughter is at 3% on the weight chart. She's small, but so am I. I'm only 5'2". She had an x-ray for her wrist and it showed bone demineralization. Someone say that in English, yeah. But no one seems to be concerned. Can KH cause this? Paul, please.
So firstly, we use bone age x-rays to look at the maturity of the bones in the hand and the wrist and compare that to the patient's age, because there are circumstances when children are small, their bone age is delayed, meaning let's say they're 3 years of age, but their bone age is 2 years of age. And then that gives us an indication as to whether we need to further evaluate that child for bone age delay. And if everything turns out to be normal, then we conclude that that patient is going to go into puberty later than average and will probably end up a normal height. The purpose of the bone age is not to look for bone mineralization, and it can be very difficult to understand the degree of bone mineralization on a plain x-ray. And so if a radiologist, a doctor who reads the x-rays, says the mineralization is low, that's concerning, because usually it means it's very low, and then investigations do need to be done. Now, it is true that there are conditions like glycogen storage disease where prolonged acidosis in the blood impairs mineralization. And I think that's something that would be interesting to note in our children who have frequent episodes of hyper or high ketones, if that can have the same effect. And I think we don't know the answer yet. Joe, you might answer that a little more because you deal with the kids with glycogen storage disease so frequently.
Paul, I have to say you're amazing. Your answer was spot on, but I agree with you 100% because a hand X-ray, as you pointed out, is typically used to assess skeletal maturity. And so when a radiologist says that there looks like there's demineralization, that usually means that there's significant loss of, because milder forms are not going to be evident. So what this child really needs, I think, is a DEXA, dual X-ray absorptiometry, which is the sort of standard test to evaluate for bone mineralization and to determine just how significant this really is. But you're absolutely right. Chronic ketosis, acidosis is one cause of bone demineralization, and of course there are many other reasons as well. But I think that that would be the approach that I would recommend in this situation.
Thank you for complimenting also Paul's comment. It's nice. I have another question. Does growth spurts and heat affect ketotic hypoglycemia? My daughter seems to do really well for a couple months of great readings, and then she starts to have a period of times where she's constantly low. Pratik.
I think this is a personal, I would say, families and kind of sometimes they have reported this, and I think whether the weather or any kind of circumstances that actually cause them to have some kind of hypos, or they are much better under certain weather conditions. I guess we probably know that obviously if they are if they are in a high metabolic state where they have to use more glucose, and whether that is what something is causing them to have this condition. But it's very difficult to say, and I've come across few families stating that. However, I don't know any condition in per se would cause where we'd say, okay, the weather is actually related to cause hypoglycemia, unless if any of my colleagues have got any other thoughts.
Thank you so much, Pratik. Anyone wants to add on that? No?
The only thing that I think Pratik sort of suggested this is that, in a climate such as ours here in the northern, northeast United States, where children are often not very active in the winter, but when the spring and summer come around, they're more physically active and therefore would be burning more energy. Other than that, I can't think of any possible association.
Thank you, Joe. And now, Mary Elizabeth.
Report that they have cycles of repeated hypoglycemia. And often the initial event might be triggered by a change in diet or an increase in activity or exercise, like you mentioned. But then, once someone has repeated hypoglycemia, the risk of recurrent hypoglycemia is higher because the hormones that help to keep the glucose up are secreted less. And so hypoglycemia unawareness or reduced counter-regulatory hormones can contribute to an increased risk of hypoglycemia. And you can imagine that can set off a cycle of recurrent hypoglycemia.
Thank you so much, Mary Elizabeth, for diving into this. And now I have a question from our families on the Faroe Islands. Can anesthesia cause death due to KH or possible GSD? My grandmother died after a pretty simple operation due to organ failure during or right after the operation, without any known cause. She also had migraine all of her life, as do I. She had high cholesterol, osteoporosis, and muscle arthritis. So now that we know that our children have KH or possible and unknown GSD, I wonder if her not tolerating the operation or the anesthesia, if that can be a sign that she possibly had KH or GSD, and is that something we should get our kids' doctors to take in consideration if our kids or myself ever need to have anesthesia? That's a long case, but anyone wants to answer that? Henrik, you get it.
Yes. It's crucial with children or adults with hypoglycemia that the blood glucose and here the ketones are measured with short intervals during a narcosis. Because there must be a fast up to the anesthesia, and that will may aggravate the hypoglycemia. So I don't know if this grandmother had her ketones and blood glucose checked before and during the anesthesia. That's step number one. To say that if the sugar and ketones are well controlled, that there still is a risk during an anesthesia, that is for me speculative. And I think not so obvious that there should be an association here. There should be some undiscovered severe disease that I don't know of in those patients.
Thank you, Henrik. And Paul?
Yes, I was just add that general anesthesia is a known factor to discover undiagnosed metabolic diseases. So oftentimes children who get intercurrent illnesses or who have general anesthesia, it might be the first time they present with an unknown metabolic disease. And what we have to remember is that in pathological ketotic hypoglycemia, we do not know the cause in everyone. And it's very possible that different people have different causes. And so I think what we always do is we have a treatment plan in place to avoid prolonged fasting with anesthesia. We feed the kids solid food at the last time they're allowed. We give them clear sugar water the last time they're allowed clear fluids. And then if the procedure is very long, we ensure there's careful monitoring and IV glucose available. And then when they recover from the surgery, we insist on careful monitoring of the blood sugar and ketones to ensure that they're able to eat and drink and stay in metabolic control. So I think for those who do have a diagnosis, you do need to sort of utilize your emergency plan for operative procedures.
Thank you so much, Paul. And that was the last question of tonight. I really, really want to thank all of you for joining this conference. It has been a very action-packed day, and so was yesterday. So thank you everyone for joining in here and making all of the scientific presentations. Yeah, Henrik?
I'd like to compliment the family organization for such a fantastic symposia. I really think you're closing the gaps between families and physicians and make them work together. It's such a huge effort and it's so needed. Thank you very much.
Thank you so much for saying so, Henrik. It has been a pleasure. And Pratik, unmute, please. I need to hear what you say.
Okay, I think I'm now getting, I think, yeah, it's end of the day, so I keep forgetting that. I think I can probably say from all of us that we all agree with this, what Henrik has said, and, congratulate to KHI and the whole team, and, you and the families who participate, healthcare professionals, everyone. It was very well organized, and congratulations to all of you.
Thank you. Thank you so much. Anyone else want to say anything before jumping forward to the...
I'd like to sort of just echo everything that has been said. And my final thought, I know that this is not practical in every single instance because of health insurance and different countries, different health plans and so on do not make it possible. But for parents who are really struggling and feel that they're not getting the answers to their questions, try, if possible, to get to a center of excellence. So, because even though, we are so-called pediatric endocrinologists or adult endocrinologists, the level of expertise in unusual and rare disorders is not uniform. So just because you're a pediatric endocrinologist doesn't mean you are an expert in rare causes of hypoglycemia. And so I think that may not always be possible for families, but where it is, I think it's worth the effort. So, if you're in the United States, go see Paul Thornton. If you're in Europe, go to see Pratik Shah or Dr. Christensen. If I have an adult, I'll send them to Mary Elizabeth Patty. But I think my message, you know what I mean.
Yes, we do. Thank you so much, Joe and Paul.
Yes, I just wanted to say that I'm excited to see all of the young research. You may notice there's a lot of gray hair in some of us sitting here, or no hair at all. I am very excited to see so many of our young colleagues doing PhDs in this area. And we know that there are many of our colleagues, pediatric endocrinologists from around the country who've participated in this meeting. And whereas they may not have been answering all your questions, they are young pediatric endocrinologists who have a really good understanding of hypoglycemia and who've been here and listening. So it's encouraging that there are many new people coming up, and we need to get them involved and bring them into the fold and let's get the patients directed to those centers where people have a specific interest. And for the really, really tough ones, Joe and I are happy to do consultations and advise and guide families. So again, Danielle and your team, thank you so much for bringing us all together. And I really think that next year we got to do this live.
Yes.
So we can all network with all of the families and talk with them at the breaks.
Yeah.
And I really look forward to coming to Copenhagen this time next year.
Yes, and that is going to happen. I will work my ass out to make sure that will happen. But I also want to just make a short shout out for both all of you Scientific Advisory Board members, but particularly one person, Henrik, who has been teaching me since I was a very young mom until the day today where I'm sitting here and we're doing research in co-production and doing research into ketotic hypoglycemia. Your dedication and your investment in this organization and in my health literacy has been immense. And I can for sure say this organization has not been here today without you. So thank you so much, Henrik. Great. And now I would like to say bye-bye to all of you. And we're moving forward just to say thank you to all of our sponsors. This could not have happened if we were not so well supported by the industry. We have industry sponsors from all over the world, and also organizations and societies. This year our conference has been featured by the Endo ERN, the Metabolic ERN, Eurotis, the Endocrine Society, the Asia Pacific Pediatric Endocrine Society, Children's Hyperinsulinism Charity, and the Fatty Acid Oxidation Family Support Group. We have been featured in the German Endocrinology and Inborn Error of Metabolism Support Group. So we have had an immense support, not only from industry partners and sponsors, but also fellow organizations doing what they can to spread the word about unexplained ketotic hypoglycemia. Hopefully very soon we will be able to share with you all a new research paper we have written. This time we have dived into a whole new research field doing qualitative research. The title of this paper really shows that we are diving into new areas and new stuff. It's called an autoethnographic study of co-produced health research in a patient organization. Unpacking the good, the bad, and the unspoken. We are reflecting upon the work in KHI, and it's going to be a blast to read. So we will share it with all of those who have registered for this conference. And don't worry, if you were not able to see all of the presentations, you will if you subscribe to our YouTube channel. Also, it's not too late to press the QR code and support the first PhD done in a collaboration with the families in KHI. Thank you, everyone. It has been amazing to see you all.